umbilical artery, the superior vesicle artery. You also have the obturator neurovascular bundle. We also have lymphatic tissues and accessory obturator vessels. It's important to note that the obliterated umbilical artery divides this paravesical space into the medial paravesical space and into the lateral paravesical space. So this is a picture taken from a laparoscopic view where we have this umbilical artery dividing this space into the medial compartment and the lateral compartment. The lateral compartment, in the lateral paravesical space, we also have a space called the obturator space, which contains the obturator nerves, obturator vessels there. It has the same boundaries as the paravesical space, except that the medial border is the umbilical artery, which is obliterated there. This space can also be developed during an open surgery, as the picture on the right shows. So this picture was taken on from an open surgery, where we have the external iliac vessels forming the lateral border, and the umbilical artery forming the medial border. And this is the lateral paravesical space. And in there, we can see the obturator nerve, which is there. I will talk about the importance of these landmarks because these are important in certain surgeries. This is also a picture showing the left paravesical space. So we're on the right now. On the left, as you can see, the left paravesical space there. You have the uterine artery, which is forming the posterior border, and we have the. So the importance of these spaces. The importance of these spaces is that they allow you to have access. Let's say in urogyne, you can, when you're doing the bulge corpus suspension.
Dr. Fadzimpofu, Dr. Nemachena, please, may you kindly mute your microphones?
So when you're doing a bulge corpus suspension, you can actually avoid going into the pre-pubic space by developing the lateral paravesical space. Also, the paravesical space is developed for paravaginal defects repair without opening the medial paravesical space in urogyne. And also, when you are trying to repair any ureteric anastomosis, you need to open the medial paravesical space in urogyne or in another operation. And also, it's used for repair of the paravaginal defects. In gynecology and oncology, when you're doing the radical hysterectomy, you have to open these spaces, especially the lateral paravesical space, for you to dissect the lymph nodes there. You need to go there and dissect the lymph nodes. And you need to realize the nerves, especially in nerve sparing surgery, so that you can avoid those nerves. The lateral paravesical space is exposed when you're doing pelvic lymphadenectomy, and the medial paravesical space gives you access to management of bladder or ureteric endometriosis. So when you're trying to approach an endometric tissue which is close to the bladder, you have to develop the medial paravesical space, and you try to attack it from the lateral side. And this is also mobilized. It is used to mobilize the bladder when you're doing anterior exenteration. I will talk about the pararectal space. The pararectal space is the space which is around the rectum on both sides. It takes the shape of the sacrum. So it's posterior to the paravesical space. Anteriorly, its borders are the cardinal ligament, and posteriorly is the presacral fascia together with the sacrum. Laterally is the internal iliac artery and the pelvic wall, and medially, some people say is the rectum, and some people take it as the rectal pillars. So I've just taken the common view that is the rectum. Of course, the discussion is to what is the border of the medial side. I think there's some authors think that they still need for more research for people to agree. So there are two different approaches to this pararectal space: the oncological approach and the endometric approach. So the oncological approach is more lateral. You have to incise the broad ligament lateral to the infundibular pelvic, and you attack it from the lateral side. Whereas in the endometric approach, the incision is made on the medial side of the infundibular pelvic ligament, and the first thing that you see there will be the ureter. In the lateral approach, the peritoneum is inside lateral to the infundibular pelvic ligament, as I've already said. Whereas in the medial approach, the incision is made medial to the infundibular pelvic ligament. So this will allow you to lateralize the ureter, whereas in the lateral approach or the oncologic approach, you want to get as much tissue as possible out as tumor. This is a pictorial which is showing the right pelvic side, the right pararectal space. We have the right ureter there. Then we have the this side we have the internal iliac, which is forming the lateral border, and we have this side will be where we have the rectum. So the ureter here has got an important role. It divides this into two. It divides this into the lateral paravesical space and the medial paravesical space. The medial paravesical space is the medial paravesical space. The medial paravesical space was first described by a Japanese oncologist, and it has been named after him. It's also called the Okabayashi space, and the lateral space is also called the Lasker space. So we'll talk about the Lasker space. The Lasker space is for pelvic lymphadenectomy, and access to the pelvic, it also gives access to the pelvic splenic nerves, the inferior hypogastric plexus, and the pelvic, we use the pelvic plexus, and it exposes the uterine artery origin from the internal artery. So when you want to dissect the uterine artery, you have to first develop the Lasker space. Then its boundaries are the cardinal ligament anteriorly. Dorsally, we have the presacral fascia. Laterally is the ureter, and the mesoureter. Medially, we have the rectum. The Okabayashi space, so I think there is a, so this is for the Okabayashi space. The Okabayashi space, you have got, these are its boundaries. Anteriorly is the cardinal ligament, and posteriorly is the presacral fascia, and laterally is the ureter. This is the medial pararectal space, the Okabayashi space that I'm now talking about. So the importance of this is that there are two important structures that traverse this space: the lateral ligament of the rectum and the medial rectal artery. These dissected when you're doing pelvic nerve sparing surgery. You have to dissect this caudally, and you immediately see the pelvic plexus. So it's important for you to realize that when you get to the pelvic plexus, you separate them. You separate the plexus and you just dissect the one that supplies the uterus and leave the one that is supplying the bladder. So this will help in having a better life after a radical hysterectomy. So its use for nerve-sparing radical hysterectomy, as I've already mentioned, and in case of deep endometriosis, it's also you need to understand this so that you actually preserve these nerves. I'll talk about the Jacobi space. Jacobi space is located in the cranial. So this is a space that is used by oncologists. It's a space which is located in the cranial portion of the vesicouterine ligament and the ureter. And this space is obtained by a slow dissection, coagulation until you get there. It contains the pelvic splenic nerves on the way to the bladder innervation. So you have to dissect until you get to where the ureter and the vesical ligament meet, and you preserve these nerves. So it's an important space that has been described for nerve-sparing surgery. So in describing this anatomy, there are 4 spaces that are used: as the medial paravesical, the Okabayashi space, the Lascaux space, and the Jacobi space. And the other 4 structures that are important is the ureter, the lateral ligament of the rectum, and the medial rectal artery, and then the deep uterine vein. So this is a pictorial showing the Jacobi space. Laterally, you can see the ureter, and posteriorly, you can see the uterus there. And this is the space that you have to develop. And underneath there's the pelvic splenic nerves that you need to preserve the function of the bladder when you're doing the radical hysterectomy. As we can see, most of these pictures are actually you get these pictures better when you're doing minimum invasive surgery. I'm going to talk about other important structures in the posterior compartment. One of them is the sacral promontory. This is like the summit of the pelvis, and especially when you have got a distorted pelvis, this is really distorted, and you use it as a reference point when you're doing your surgery. And this is where you also do whether you decide to do the lateral approach or the medial approach. I also talk about the importance of the external iliac vessel, which is also found in the posterior compartment. It's important to know that this vessel, it's from the common iliac. There's division into the internal iliac and the external iliac. The external iliac then runs laterally just along the iliopsoas muscle, and it does not give an anterior medial branch until it gets to give the medial branch, the inferior epigastric artery, which then runs anteriorly and forms the lateral ligament on the anterior abdomen. So this is a good space to start your lymphadenectomy, because there are no vessels on the medial aspect of this artery, and you can see it's a bigger branch of the common. When they divide into internal and external, is the bigger branch. And of note is that there is no anastomosis with there are no big anastomosis with this vessel, so that if you inject, then you have because this is the main supply of blood to the lower limbs. So if there's a damage to this, you actually can cause problem to the blood supply to the leg. So it's important to recognize it, and it's also important to avoid damaging it. And it's also important to know that on the medial aspect of it, there are no vessels, and then you can start your lymphadenectomy on that aspect. I'm going to talk about the uterine artery together with the internal iliac artery. This is important to know.
Dr. Ngwaru, two more minutes to go.
Yeah, I think I'm left with 2 more slides, then I'll be out.
Thank you.
So this uterine artery, because it transverses this posterior compartment, it's important to also realize that the uterine artery is always in between the ureter and also the external iliac vessel. And the first branch that is given is the uterine artery, and then after that there is the superior vesicle or the obliterated umbilical artery, which when you follow from the anterior abdomen, you can actually follow it back and you can identify the uterine artery. It's the only artery that is given medially from the internal iliac, which crosses the ureter, and you can use this knowledge to clamp when you want to do for big myomectomies, or if you want to reduce blood loss during postpartum hemorrhage. So the distance between these also gives you room to be able to tie this and clamp this uterine artery. Quickly through the nerves, we know that there's autonomic nerve system, the inferior hypogastric nerve, which comes from the T10 to L2, and the pelvic splenic nerve. This may, and then they form the inferior hypogastric plexus or the pelvic plexus, which supply both the uterus and the bladder. And it's important to identify this and when you're doing nerve sparing hysterectomy. So with the knowledge that we have in the posterior, you can actually preserve these nerves. So in conclusion, that knowledge of the posterior anatomy is essential for every pelvic surgeon, whether you're doing oncology, or you're doing endometriosis, or you're just doing gynecology. It's also important even for obstetrics when you want to reduce the blood loss. So it's important for us to know this pelvic anatomy now that we have minimum invasive surgery that allows us to magnify these spaces. Thank you. That will be my last slide. Thank you, Dr. Grant.
Thank you so much, Dr. Ngwaru, for such an insightful presentation. I think one of the things is you think you know anatomy until you actually start studying this anatomy, then you realize that you have more anatomy to learn. In the interest of time, I will skip questions for now for you, but we have them at the end of our segment. Please allow me to just, as Dr. Robert Nyajena starts to share his screen, to make an important housekeeping issue. Please, if you're not presenting, make sure you are muting your microphone because it distracts or disturbs the presenter. Another announcement is that this is the Zimbabwe Society of Gynaecological Endoscopy's annual scientific congress, and we're going to have elections at the end of the day. So you can send your nominations through to Dr. Nyakanda now as the meeting is going on, and then we're actually going to have the elections at the end of the day. Allow also once again that I thank our presenters who are from New Zealand and other countries beyond our borders who are actually with us. Now about Dr. Robert Nyajena. When you are talking of Nyajena, you're basically talking of passion. One of the things that he has done is he has driven from Bulawayo over weekends for meetings, for trainings and so on Sunday, and then he has to go back. So he has sort of shown amazing commitment. He's a specialist obstetrician gynecologist based at Mpilo Central Hospital in Bulawayo. He obtained his MBCHB degrees from the University of Zimbabwe in 2011, and then he went on to obtain his fellowship of the College of Obstetrics and Gynecology in South Africa in 2019, and he is also a fellow of the College of Obs and Gynaecological. He's part of us in the Winners Program, and like I said, he's shown so much commitment. This morning is going to talk to us about a very important topic, which is energy systems in endoscopy. Dr. Nyajena, over to you.
Okay, thank you, Dr. Grant. I don't know if my screen has started sharing.
Yes, we can see your screen, so just start your
Which one are you seeing?
It says ZSGE trends in gynecological endoscopy.
Okay, but now how do I play it?
So go to the top where it says slideshow.
You want me to go to where?
At the top of your screen, just go to where it says slideshow next to animations.
Top of my screen.
Yeah, do you see that if you follow from file, home, insert, design, transitions, animations, then you see slideshow.
Or on my screen. So
yes.
If I do this, are you able to, let me just, you can see my screen now.
Yes.
No, that's fine. Thank you so much. Thank you, Dr. Grant, for the introduction. Like what he has always been, what he has already said, that I'm based in Bulawayo, and I'm part of the Winners project. So my topic today is mainly on the energy systems that are used in endoscopy. I've got no conflicts of interest to disclose as I do this presentation. And then basically the outline of my presentation, I'll briefly talk on the introduction so that I'll introduce the energy use in endoscopy. I'll talk a bit on the technological and safe electrosurgery, talk a bit on complications, then also go on to the alternative sources of energy that are now being used and that are now trending now. On the image there, that's Mr. William T. Bovey. He's the first person who produced the generator, which formed the basis of our electrosurgery. And this generator was used about 95 years ago. That's in 1926. So he is basically the father of electrosurgery. But before him, of course, there were other things that had happened, which led him to be motivated to produce that generator. So just a brief background history into electrosurgery. You find that electrosurgery, it started as early as 3000 BC, where the Egyptians were actually, have been recorded to have used heat to treat ulcers. And then also you find between 469 and 370 BC, Hippocrates was actually also an advocate of electrocautery, where he also used electrocautery as part of his treatments. And he's actually famous and known for one of the statements where he was actually saying those diseases which medicines do not cure, iron will cure, and those which iron cannot cure, fire will actually cure. So he was actually referring to the use of heat. And then he goes on to say, where fire cannot cure, then that disease is actually incurable. Then moving fast forward into the 10th century, a guy called Albicasis actually used heated instruments to treat disease and stop bleeding. That was basically cautery as well. Into the 19th century, we also had what Becquerel, who was the first to use direct electro current to heat a wire. That was used in electrocautery. Into 1881, Morton then discovered that you can actually increase the frequency of electricity to above 100 kilohertz. And when it passes through human tissue, it would not cause neuromuscular stimulation, as for frequencies below 10,000, you have neuromuscular stimulation. Then in 1891, that's where you have Dasoval, who also reported the same current had a heating effect on tissue, which was basically where they were actually now developing this electrosurgery. And then just fast forward to 1900, then you had Rivet, who used electrosurgery to treat a hand ulcer. Until then, Bove in 1926 then developed the first generator, which was actually used by Cushing to exercise a vascular myeloma, which was in the head. And it's actually documented that this was in Boston in October 1926. So that's just basically the background is of where electrosurgery has come far from. And then basically, when you then look into these energy sources, you find that over the years, power sources used in endoscopic surgery are actually varied and they're actually numerous. And as technology has progressed, there have actually been improvements over the years from when they started to do electrosurgery. And as this improvements actually happening, it then becomes of paramount importance that knowledge of principles of safe use of the surgical energy is critical in the practice of any endoscopist. And electrosurgical energy, being one of the energy used in surgery, is actually widely used in most operating rooms. So basically, what is our electrosurgery? It actually just refers to the use of high radio frequencies with alternating currents to raise the intracellular temperature in order to achieve various thermal tissue effects, which include cutting, desiccation, and coagulation. And it also follows our basic physical rules of electricity. So those that did electricity, that did physics in high school will actually be marveling around this, because that's where you talk of your energy, your voltage, your wattage, your resistance, and so forth, because that's what it basically follows through. And when you look at electrosurgery, it basically utilizes two poles, which we call the active and the dispersive electrode. And then these two poles can then be split, where you then have your bipolar energy and your monopolar energy, where in bipolar, both electrodes are actually within one instrument that's in the surgeon's hand. And then in monopolar, you then have your dispersive electrode, which is the grounding pad attached to the patient. And the active electrode is the one which is in the surgeon's hand. Then how does these things work? That's the art of instrumentation. You're looking at where electrosurgical works by concentrating the current that's increasing the density at one point, that is on your active electrode, to produce the desired thermal tissue effects, and dispersing it via the dispersive electrode to prevent unintended tissue burns. So in your bipolar, it's actually within the same instrument, and then your monopolar, then that's your dispersive electrode. And then to increase this thermal effect, it is important to make sure that you avoid this temptation to step up on the electrosurgical unit wattage to increase the current, which would then actually increase the risk of unintended tissue burns. They actually measures that you can actually do if you want to change or if you want to improve the effect of your electrosurgery on tissues, which then what we call the factors that modify your electrosurgical tissue effects. One of the factors that really affects the success of electrosurgery is the waveform that you're going to use. So you find different electric waveforms actually have got distinct tissue effects, where a continuous sinusoidal wave with high current and low voltage will cause a rapid rise in tissue temperature up to more than 100 degrees, which then vaporizes or cuts the tissue. That's our cutting mode. And if we are so used to the electrosurgery, that's where we press on the yellow button or on the yellow pedal. Then when you use interrupted waveform with low current and high voltage, this actually causes slow increase in temperature to rise to less than 100. That's between 60 and 100, which then causes your desiccation and coagulation. That's our coagulation, or our blue pedal or blue button on the instruments. That's one of the factors that modifies electrosurgical tissue effects. The next thing is our power output. Most times we've seen where we are failing to achieve our effects. You want to see people who want to increase the wattage and say increase to maximum, but actually it's the opposite. You actually see that generally the use of low effective power for desired effects is actually is actually better, as higher wattage is actually associated with increased risk of unintended tissue pains. So you find in your cut mode, you can actually work with as low as 50 watts and go to the maximum of 80. And when you are looking at the coagulation, you want to use between 30 and 50. So when you push your coagulation power to 60, you actually be trying to risk the patient and increase issues of unintended bends on the patient. Then other factors that actually modify your electrosurgical effects is actually the surface area of your electrode. You find that a smaller electrode has got higher current concentration and density, where if by just reducing the contact area by a factor of 1 will actually increase the current density by 10. That's if it's reduced by 10, then the current density will actually increase by an effect of up to 100. Then the next thing is your activation time. We should not actually be holding or using our electrosurgery contact for a longer time, as this increases actually the risk of tissue damage. And then the next thing is tissue contacts, where different contact modes have got different effects on tissue. You find when you're using the cut mode, you actually don't need to be touching the tissue. You just need to be between average 1 millimeter from your tissue, and then you have your cutting effect. And then on coagulation, that's where you need to touch your tissue, but not for longer time as well. And the next thing that also has got effect on our electrosurgical tissue is the tissue impedance, where thermal changes actually increases with increased tissue impedance. So you find those tissues with high water content actually responds much better than those with low water content. That's for our muscles and skin, it's got less impedance, and they are actually highly responsive to this electrosurgery, whereas your scar tissue and fat, and where there are eschars, there's actually higher impedance. Then the next thing is where you are using your electricity, of course, complications will come. And these complications are not very uncommon. They do happen every now and again, to such an extent that the incidence of electrosurgical injury is actually higher, to the range of with an incidence of between 2 to 5 per 1,000 cases. And in every year, there's actually approximately 40,000 patients which would have been reported to receive electrosurgical pains. And the unfortunate thing also is nearly 70% of these injuries are not recognized during surgery. So it means these are picked up late, some as late as day 7, some even up to weeks afterwards, where you then find that your patients actually have got they've got a fistula, they are actually ureteral injuries during surgery and so forth. And these actually two form the most common areas of electrosurgical injury. That's your bowel and your ureters, amongst other tissues also that can be injured. And then what are the common patterns of these electrosurgical complications? There are complications related to the active electrode during surgery, and then those that are also related to the electrosurgical units. So active electrode injuries, that's where you have got your direct application, where while it's heating, you overpress, or there's actually overheating of your tissues where there's direct application. Then the other one is the inadvertent activation, either by mistakenly stepping on the pad or by mistakenly pressing up on one of the activators. That's your electrode injury. Then you also have got residual heat. After an instrument is used, some of them, they retain heat, especially our ultrasonic NH devices. You find that they retain heat, and once they are placed on sensitive tissue, then you have residual heat on those tissues. So that's as far as the active electrode injury is concerned. And this can actually be prevented by making sure that your active electrode is always in your view, usually directly in your view, and then unnecessarily stepping on the pad, and then stepping on the pad when you're sure of which tissues you want to touch, and then also avoiding contact with other closed tissues whenever you're activating your electrodes. Then the other complications actually come as a result of insulation failure, very common in our developing countries, where we repeatedly use our instruments until they actually have got insulation failure. And it's actually been recorded that the distal third is one of the areas where you've got higher risk of insulation failure. And to prevent this, we find most manufacturers now, what they do is they make sure that the instruments are insulated double. So usually there's an outer layer and then there's an inner layer. The inner layer is usually yellow. So when you're using your instruments and you start seeing that there is now a yellow appearance on the instruments, then that instrument should not be used because it's actually at higher risk of insulation failure. Some areas which also predispose to insulation damages is actually during sterilization, where by repeatedly using and repeatedly sterilizing instruments, you actually be damaging the insulation. And the next one is actually your antenna coupling, where energy is actually lost through the electrical cables, and then it can actually be coupling with other closer instruments and resulting in heating. Then the next thing is our direct coupling, where you have two instruments actually touch each other unintentionally, and the active electrode will then activate the other instruments, resulting in electrosurgical burns. Then the last one is your capacitive coupling, where in capacitive coupling now, these are actually two insulated instruments, which then heat is transferred to the other non-active electrode and result in electrosurgical injuries. So that's as far as complications is concerned. We can go even further to describe how we avoid them, how it becomes more prone and so forth, but just basically an overview of how these complications do happen. And the next thing is what I would want to discuss is the issue of advanced electrosurgical instruments that have been there on the market after the conventional bipolar device. A lot of development has actually happened, and this actually has been motivated by increased uptake of the complex laparoscopic surgery that has been happening. A lot of surgery is now happening, laparoscopic hysterectomies, the gynecologists, they now do your VTEMs, hysterectomies and so forth through laparoscopy. So these advances and progression, this has actually pushed for advances and progression of NH technology that has brought to the market various devices. And the aim is basically to deliver safe, efficient hemostasis and desiccation. So we find on top of our conventional bipolar devices or our electrosurgical instruments, you now have other instruments that uses advanced bipolar, such as the advanced bipolar devices. We've got example of your ligashua, Ensil, and Kamin. Then you also have got ultrasonic devices. That's our harmonic scalpel, the Lotus, and the sonic beat. Then you've got the hybrid devices, which then combines the advanced bipolar devices and ultrasonic devices. An example is our Thunderbeat. Then you also got plasma devices such as the plasma jet, and the laser device such as the Lumenis AcuPulse. These they do come also with their advantages and certain disadvantages. And above all, there's also the economics of these instruments when we do use them. They also have a bigger financial implication. And calculating of this financial implication is actually complex, where you now need to look at the net cost of using this particular device compared to the alternatives. If I use this one, does it really give me an advantage over the other ones? Where you're looking at the cost of generators that are going to be used, as this requires special generators, the cost of staff training, device maintenance, and the cost of use of these components, as most of them, they're actually single use. But then you then look at the advantages that we have at the end. Like, you know, if reduced operating time, the complication rates get less, and then the hospital stay also does get less. So just looking slightly deep into these advanced NH devices, like what I said, advanced bipolar devices, these ones actually will combine your electrocoagulation with the integral blade to deliver hemostasis and the cutting in one device. So it actually minimizes your surgery time. Instead of just having to use the coagulation and then cut afterwards, this is actually combined in one unit. Like what I said, the ligashua, Ensil, and the PK cutting forceps and Kamen are actual examples. And then it also requires a specialist NH generator. Its own advantage now is it has got consistent vessel seal. It can seal up to vessels that are actually up to 7 millimeters in diameter. It also has got hemostasis feedback. While you are using it, once you have achieved hemostasis, it actually gives you a feedback by a beeping sound. Then it also has got the cutting blade within it and independent of coagulation. But however, the disadvantage is still remain that it's still a two-step process where you initially start by coagulating by stepping on a certain button, then you activate the cutting mode after hemostasis is achieved. It is also less suitable for your fine dissection. It has got a disadvantage of lateral thermal spread, whereby if you're holding your instruments, the energy can actually disperse to other nearby tissues, or the tissue which is affected is actually wider than the desired. So this is just an example of the LigaSure instrument. Then the next one is our ultrasonic devices. These ones actually utilizes ultrasound to seal vessels and cut tissue without the need for an integral braid. And it actually uses instruments. These are actually single-use instruments. That's the disadvantage that they also have. But we have our common harmonic scalpel provided by Ethicon, then you've got the Sonicisen, and then the Lotus. And then the advantage is, like what I said, is these ones actually have got fine dissection. It's actually a one step compared to the advanced bipolar devices, and then there's actually no radio frequency energy when you're using the ultrasonic device, and then it also avoids neuromuscular activation, so there's no activation of the neuromuscular or damage to the nerves and the tissues. It also has got reduced surgical plume and smoke, as this one does not use radio frequency. There's actually, the heating is actually much less, so there's less smoke and less plume. Then it has also reduced lateral thermal spread compared to our advanced bipolar devices. The disadvantage is it doesn't seal now bigger vessels. So vessels that are bigger than 5 millimeters, you cannot use these ultrasonic devices. And this also is the one that reduces your residual heat. So you find after using the harmonic scalpel, if you just leave it without noticing where the tip is, the residual heat can actually hit your other tissues, can actually go on to damage your bowel, your ureters, and so forth. And it's also more costly than the advanced bipolar devices. So that's how the harmonic scalpel is like. Then the next one is the hybrid NH devices. These ones are the ones that now combine the effects of your ultrasonic devices and your bipolar NH devices. And currently, only device in this case capability is the Thunderbolt. It actually is used to seal vessels up to 7 millimeters in diameter. The advantage is also
Dr. Nyajena,
yes.
1 minute to go.
It's okay. I'm left with about 3 slides. The advantage is actually it's consistent vessel seal, sealing up to 7 millimeters diameter, the fine dissection, reduced instrument traffic, because now you've got all your electrosurgical effects in one instrument. It also has got improved efficiency and hemostasis feedback. The disadvantage just being that the residual heat that happens with your ultrasonic devices is it has got the ultrasonic effects, and then it also requires a specialist generator. So that's our Thunderbolt there. In the different parts, I'll just skip through so that at least I'm able to finish up my presentation on time. Then the next one is the plasma device, which utilizes radio frequency energy to create a plasma jet capable of causing superficial hemostasis and cutting. So the example, that's your plasma jet, can be used or for shallow unified hemostasis, and then so tissue ablation and superficial tissue cutting. The advantage is it's also precise tissue effects, minimal lateral thermal spread, no residual heat on this plasma device, and there's also no smoke production. Disadvantage is actually it's mainly used on the smaller vessels, and then there's risk of raised intra-abdominal pressure, then the potential gas emboli on these plasma devices. And then last but not least is our laser device. Laser is actually always been used by the gynecologists, by the ophthalmologists and different surgeries, but it can also be used during endoscopy. And our laser is actually just an abbreviation of our light amplification by stimulated emission of radiation, and projects a highly concentrated beam of light through a stimulated emission of photons. The advantage for laser is it's extremely precise on its effects. It has got minimal lateral thermal spread, and also it has got minimal tissue penetrance. But the disadvantage still comes with the issue of the diameter of vessels that you can seal. So it's actually smaller vessels only. It's inefficient in dissection. And then it also requires special staff training when it's supposed to be used. Then the optical damage from the laser while it's during using it. And then the implementation cost of having these devices, and then the maintenance cost as well. And since it uses laser, it also has got higher risk of initiating fire. So it was a very higher fire hazard risk, and then the surgical plume that it also produces. So basically, just concluding my presentation, it is basically just good to have an awareness of all available energy modalities, which allows operators to select the optimum devices. And then minimum access surgery actually need to minimum invasive surgeons actually need to demonstrate a comprehensive understanding of instruments to ensure that surgical success is achieved with good safety. Thank you.
Thank you, Robert, for a very comprehensive presentation on energy systems in endoscopy. I'll give time for a few questions for you and Dr. Ngwaru. So if anybody wants to ask Dr. Nyajena or Dr. Ngwaru any question, you can show by raising your hand, or you can type your question in the chat box. In the meantime, I don't see Dr. Joseph Shava in the meeting. So Dr. Vuma, you could start sharing your screen and present. Then we will have Dr. Shava's presentation when he joins. So anybody with any burning question or a comment for Dr. Nyajena or Dr. Ngwaru, who presented on the anatomy of the posterior compartment?
No, I'm trying to share my content. I need to be allowed apparently to come into.
Artonde, can you please allow Dr. Vuma to start sharing a screen, and Dr. Nyajena, you can stop screen sharing. All right, I don't see any raised questions, any raised hands for now for questions to Dr. Nyajena and Dr. Ngwaru. If you do have any questions for them, you can type them in the chat box and we will discuss them at the end of this segment. Ladies and gentlemen, allow me to move to the next presentation, which is going to be shared by Dr. Eaton Vuma on transabdominal sacrilege, a single center experience. Now about Dr. Vuma, I'm going to read his profile for you. Dr. Vuma is actually a Zimbabwean who graduated with a Bachelor of Medicine and Bachelor of Surgery degrees from the University of Zimbabwe in 1989. So he's been around for quite a while. And then he moved to South Africa, where he obtained a Master of Medicine in Obstetrics and Gynecology from the University of Pretoria in 1999, before a lot of us had started med school. And he also acquired his fellowship of the College of Obstetrics and Gynecology. Dr. Vuma is a laparoscopic pelvic surgeon, which qualification he obtained from the European Academy of Gynaecological Surgery in 2019. He's got a certificate in clinical neuropelviology, again obtained in 2019. And he is a certified surgical coach of the Academy of Surgical Coaching, USA. And yes, I would want to appreciate Dr. Vuma for his commitment and agreeing to mentor us as we go through the winners program. Dr. Vuma, may you please take over the time and make your presentation.
From start. Good morning, everyone. I'm having technological issues. Can you see my screen?
Not yet, Doc.
Oh, wow. No.
Yes, the host allowed you to share?
I think so. Let me see, share content. This Google Drive. Wow, it's taken me back when. Sorry, okay.
So you have sharing rights now. You should be able to
Now.
share. Yes, and Tonde,
Asking me
please
to
also,
sh-
yeah.
It's asking me to go through the share my screen. What's this one?
In the meantime, Tonde, please watch the waiting room. There are people who are waiting to be admitted. So if you can admit those people. Dr. Vuma, have you opened your presentation on your?
Yes, I have opened my presentation.
Okay, that's fine. And you're
But
trying
I'm not
to,
sure, where should I go?
where it says share screen.
So share screen.
Yes.
On the thing I have said, yeah.
You can see the share screen button.
Yes, I've pressed it.
Okay, is it now giving you options to share from your screen?
Yes, yeah.
Okay, maybe then you just press your presentation and try.
This is just frustrating me, sorry. Share my screen. So,
Right. Dr. Vuma, is it okay if you send your presentation to me and then I can
I've already sent it to him before the.
Okay,
Yeah.
so yeah, Tonde, can you please share Dr. Vuma's presentation? All right, so Tonde is going to share it on your behalf.
Okay.
Yes. Tonde, are you making progress?
Hello.
Hi, Dr. Vuma, still waiting for Tonde to share.
Okay. Okay.
Yes, Dr. Vuma.
Yes, hello.
Yes, please confirm. You sent your presentation to which email?
Both of them.
Okay, that's fine.
All right, so whilst he's trying to share, I'll do some basic reminders once again. Remember, it's the Zimbabwe's Society of Gynaecological Endoscopies annual scientific day, and we are going to end the day with elections. And so feel free to send your nominations for the positions under contention to Dr. Nyakanda. Dr. Nyakanda's WhatsApp number has been shared, so you can actually WhatsApp him directly. That's the first thing. Number two, if you are not sharing or talking, please remember to mute your microphone because voices can really be distractive or they can disturb. If you've got any questions for the presenters, you can type them in the chat box so that at the end of the session, we can actually have those questions answered. And please feel very free to participate. This is everybody's meeting and discussions will make it more exciting. So please, let's type in those questions or let's raise our hands at the end of it and make some interesting discussions. Tonde, how far are you now?
Okay, I've actually sent the reminder to Dr. Kutivandi send it afresh because in our emails right now I don't have it. I think she said he sent it to our other email.
Okay.
Yeah, so you may need to check your emails, Tonde, because we have asked everybody to just share your presentations to you as backup in case people have problems sharing, and we send them earlier on.
Because on my side, let me see, sent. Yeah, on my side, I sent the two at 8:25.
Okay, maybe you can try.
Okay, please confirm though. Please confirm you sent it to which email?
I sent to both emails, the ones that I have, the ones that they sent us on the, let me check on the group, yeah.
Okay, I might not have access to those emails. Please send to the ones I have sent you in the chat now.
Now, okay.
Yes.
I use two cell phones, so. Which one did you send to?
So send to Tonderai @gmail.com.
Just hold on. Let me get that.
Tonderai as in
Tonderai.
yeah, Tonderai,
yeah.
Yeah, Tonderai @gmail.com. Yes,
yeah.
@gmail.com.
Okay.
Yes.
No problem. I'll do that now. Yes, I've sent.
So Tonderai, please confirm receipt of the email.
Right, I'm just refreshing my inbox now, so I hope to have it in the next 5 to 10 seconds. Yes, I've received your email, Dr. Guma, but on your email, I've realized that there are no attachments.
There are no attachments?
Yes.
So, yeah. On both of them, because I sent you two now.
Right, you may start now. I've received another forwarded.
I can start now.
Yes, please confirm you can see your screen.
Yes, I can see my screen. Can I go ahead?
Yes, please go ahead.
Good afternoon, good evening, everyone. Thank you for the opportunity to share my experiences. And I'd like to concur with Dr. Mtlanga that, I mean, there's been a long journey on this for this society. So it is really a proud moment that I'm still was associated with the Zimbabwe Society for Gynaecological Endoscopy. Next slide. Do I move it? Next. I move. Okay, so in terms of the topic I chose is about insufficiency, and the definition according to the American College of Obs and Gynae in 2014 was an inability of the cervix to retain a pregnancy in the second trimester in the absence of uterine contraction. So basically the diagnosis can be achieved either by history of two or more consecutive pregnancy losses between 14 and 27 weeks. And also by ultrasound, if there has been documented use of preterm delivery before 34 weeks with a cervical length that was measured at less than 25 millimeters. And the other one is also by vaginal dilatation, by pelvic examination, where you find the cervix is dilated, effaced, but there are no contractions at the gestational age of 14 to 17 weeks. Personally, I think I have some reservations about those definitions because I think one loss is one too many. And I think in this modern day, when women are living, when they're falling pregnant at an advanced age, it's actually, we can't wait for two pregnancy losses. And also the definition of vaginal dilatation, it can happen later. Yeah. Okay, next one. So basically, cervical incompetence is said to complicate about 0.1 to 1% of all pregnancies. And then there's been one pregnancy loss, the risk of recurrence is quite high, about 30%. And then to the traditional, whether you were doing McDonald or chirurgical circulation, about 30% or so seem to fail. The first guy who's been documented in the history is the chirurgical who decided to put in India in 1955. And McDonald simplified because with the chirurgical, you need to dissect the anterior wall and then the posterior part of the cervix. So it's actually more involved. And then McDonald is actually the most commonly used modification where you don't need to dissect this in and out. And I think that's most commonly used cervical circlage that's been done. And in 1965, Benson and Duffy have been credited with doing the first trans-abdominal sectional edge, which they did in 1965. So basically then over the years, there's been little interest in the adoption of abdominal circlage, mainly because it was obviously done with a laparotomy. So the patient needed two laparotomies, one to put in the circlage and two to do the delivery. So obviously with the morbidity and associated with laparotomy, it actually failed to distribute. So basically laparoscopy has actually picked up. So now more and more, I think there should be a resurgence and we should really look at whether we can do a laparoscopic circlage, which has been proved to be safe, effective, and reproducible. Next. Next slide. Yeah. So basically, there's a visual representation. Previous. The picture. Yes. So basically, those are the differences where the short guy is higher and the McDonald circlage is lower, and then the trans-abdominal is actually a bit higher. The next one. So basically, those are the indications where for your abdominal sacrilege, where you previously failed abdominal sacrilege, extremely short cervix, or if ever there's any history of trachelectomy, and even if you have recurrent pregnancy losses without any joy with the sacrilege. But more and more, there's a move to actually do primarily laparoscopic abdominal sacrilege. Next. So basically, in transvaginal sacrilege, the timing usually based on history has been reported as between 12 and 14 weeks. On average, I normally do mine at around 16 weeks, but it also depends on the history. And then for those ultrasound indicated sacrileges will be around less than 24 weeks. And the majority of cases that are done will obviously transvaginal sacrilege where there's going to either emergency or rescue sacrilege at less than 24 weeks. Next. So basically we've gone through this about the previous the indications for the transabdominal sacrilege. Next slide. So basically, when should we be doing transabdominal sacrilege? Most of them are usually preconceptual. This is much easier, and there's less blood loss, and this usually can be done laparoscopically as a day procedure. And then when they are pregnant, it's actually technically more difficult. I think the cutoff point should be about 16 weeks, but maybe 18 weeks. I've learned the hard way. I used to go up to 22 weeks, but technically it becomes very difficult and to manipulate that uterus outside the pelvis and pass the suture. So I think generally 16, 18 week size uterus, you should actually be able to manage. Next slide. Yeah, so visually, this is a schematic drawing of exactly where you put the transabdominal sacrilege. So it will be just above the cardinal ligament between the uterine artery. So there has been discussion, do you go medial to the uterine artery? So that involves obviously dissection along the thing that also has a risk of bleeding. Or now they say, there's a review where they say you can actually even put lateral to the uterine arteries where there's no need for dissection. And apparently the pregnancy outcomes have been reported to be in a systemic review to be similar. Next slide. So if in case you do a laparotomy, this is basically almost the same. This is just a schematic drawing to say you try and open a window between the uterine arteries and then try and put it at the ischemico-pelvic junction. Next slide. So basically, in the procedure, you basically retract the uterus by pulling on the round ligament. You then open and reflect the bladder peritoneum. So basically, I pull the round ligament and pull on the bladder peritoneum, and then usually using monopolar, you can actually, like Dr. Nyajena was alluding to. So it's basically a non-contact mode. It basically would actually cut, and it actually also causes hemostasis. So you can actually then open the peritoneum all the way from the right round ligament to the left round ligament, and then just push the bladder down onto the cervix. And then you reflect the bladder down, and then you then go from, you normally start medially. You try and expose because obviously the vessels are running vertically up. So you try to expose them as much as you can. And then you then open lateral to the vessels. You then open a peritoneal window. So you normally push in an instrument from the posterior aspect, open the posterior peritoneum of the broad ligament, and then you open it widely from almost about the isthmus, and then you then open it all the way down, And then generally I put in using a retrograde loading technique. You remove the 5mm port, and then you then push in the mescaline suture. I generally use a mescaline suture, which is a 5mm suture with the big needles. And then I take a generous bite. So you do everything under vision. You then pass the suture from medial to lateral. So medial to the uterine vessels, and then you open the needle will come out through the broad ligament opening. And then you then pass the suture behind the uterus, and then again, almost just above the level of the uterosacral ligament insertion, you then pass the suture the other way, and then you cut off the needles, and then you then tie it snugly. And some people, if the patient is not pregnant, some people put in a Hager's dilator 5mm. Some people put an 8mm Hager dilator into the cervix so that it should not obliterate it. But technically, it's very difficult to actually make a tight knot with the mescaline suture. So you normally put 5 to 7 sutures, and then to prevent it from sliding, I normally use either proline or silk to tie the ends together. And then after that, you close the anterior peritoneum. And so generally in the interval, which is when patients are pregnant, it's actually much easier. So when they are pregnant, it's technically more difficult. Next slide. So basically, just in summary, in your with laparoscopy, so in the dorsal lithotomy position with the urinary catheter in situ, I normally use about 3, sometimes 4. So 3 ports when the patient is not pregnant, and 4 ports. So I use an ipsilateral suturing position. So I have I stand on the left, I have 2 ports, one in the mid-clavicular line parallel to the umbilical incision, and the other one also a bit about 2 centimeters from anterior iliac spine, just a bit lower. And then if the patient is pregnant, I'll need my assistant with a retractor, with maybe a 5 or a 10mm liver retractor to come in from the right lower quadrant. So if obviously you have to choose, I normally use a umbilical port with a 10mm visual entry, or if there's any contraindication, I would then, or if the patient is pregnant, we have a 5mm Palmer point entry. So this is what we've basically gone through. Next slide. So basically the controversies in terms of the technique is whether the one we've described is where you open a window and then you either pierce, you open a window middle to the uterine artery. This I think is actually risky because there's always a higher risk of bleeding, inadvertent bleeding, because the uterine artery is usually medial and the vein is usually more lateral. So there's always a trend of a risk of bleeding. And then the one I usually use is where I pierce the cervix without actually, and as I alluded to earlier on, there's been a systematic review by Mowat where he compared whether does it really make any difference whether you put the vessels medial, you put the suture medial or laterally. So if you do put them laterally, you don't need to dissect the vessels. But there's been articles published about obviously the Doppler flow in terms of the uterine arteries after putting the suture lateral. Does this not result in intrauterine growth restriction? So they've found actually they've been changed, and obviously the uterine artery evolves throughout the pregnancy, but there's been no systemic or there's been no confirmation that it actually causes intrauterine growth restriction later on in pregnancy. Next slide. Now, next slide. There's no video. I couldn't. No, next slide. I was meant to download the video, but I suppose, this is the last. So sorry, I got permission from the mother. These are some of the twins. This patient had twin pregnancy. And the sad story where the 3 children, we did a sterilization, and then at 3 years old, the child died. So they then went and did IVF. And then at 20 weeks, she presented with bulging membranes. And at that time, I just managed to then take her to theater, lavage. And then I managed to, with using warm normal saline and swabs, to put it in steep Trendelenburg bag, did a laparotomy, and did my first transabdominal sacrilege. So those were the twins that were delivered in, I delivered them at 30, I think I put this at 20. We managed to deliver them at 31 weeks. And they're both chess champions in South Africa. Next slide. So this is my personal experience. So from 2014, I mean, that one was, it was not included in this series that I have. Then basically the indication for in my patients were the patients who have had previous failed vaginal sacrilege elsewhere, and then the ones who had also had second trimester and third trimester losses, and then clinically it's patients with short cervical osses. And over the course of from 2007 progressively, we used to have a lot of patients that used to present around between 22 and 24 weeks with ruptured membranes. So basically the question was always, the pressure was, could we have prevented this? Because now the new concept is, what is cervical incompetence? Now there's a theory that obviously there is inflammation. So, or there's actually change in the microbiological flora, which is ascending, which causes the cervix to become soft. And then that was then followed by obviously dilatation, intrauterine amniotic fluid infection. And eventually these patients used to present with ruptured membranes. And then the neonatal outcomes were terrible. So basically from then on, I learned from around 20 weeks, I always do 18-20, I always critically do a transvaginal sonar to measure the cervical length. And one of the things I also found out from my own experience was that measurement is not enough. You need to feel the consistency. So generally, if you find the cervix is soft, mushy, if you look at the original Bishop score, cervical consistency was one of the things that were used to assess whether the cervix was favorable for induction or not. So as a result, I've actually found out that in terms of fetal wastage from these ruptured membranes has actually become almost like come to zero, because I'm actually aggressively looking for these cervical changes, which may not be picked up by only looking at cervical length. And then besides the whether you would put a transabdominal sacrilege, or if there's some patients I think I remember 1 or 2 where we tried to put in the preconception sacrilege, and they were always present in pregnancy. And then you're already, although you have had the discussion before, but then now we are in trouble, they're already pregnant, so you must actually do something. So part of the adjuvant treatment, obviously one of the big problems with transabdominal sacrilege or cervical sacrilege in general is based on case series. There's been no randomized controlled studies. And I think some people deem that if you do a transabdominal sacrilege, having a randomized controlled study is unethical. So part of the adjuvant treatment, which obviously has no, is not evidence-based, is the use of antibiotics, either vaginal or oral progesterone, that I routinely use. And then one of the other things that on part of my, from even when I do vaginal sacrilege and also transabdominal, I always lavage the vagina with about 1 liter of normal saline, based on the theory that most of the vaginal flora is either there is infection or it has actually shifted. So that is what caused the ruptured membranes after the insertion of the thing. Next slide. So during that period, I've managed to record about 10 patients, and then 7 were managed laparoscopically and 3 were abdominal. And I think one of the 7 was a conversion. I think one of the patients was supposed to have an interval or pre-pregnancy sacrilege, presented in pregnancy at about 22 weeks. And then whilst we were trying to put in the suture, introduce the needle, then there was vessel injury at the level of the isthmus, and then there was torrential bleeding that we had to convert to laparotomy. Unfortunately, there was that fetal demise because of the bleeding. Then the one that I've done preconceptually were all done laparoscopically, and then the ones for laparotomy were about 3 and 3 laparoscopically. And then of the 3 laparotomy, one is the one was initially laparoscopic, which was then converted. Next slide. Basically, those are the patients, and then and that's the time when they actually then delivered. I think the other 2 that I could not follow up, they were actually referred from, one was from Brits in the Northwest Province, one was from Pretoria, so I couldn't actually I've actually lost contact with them. I tried to get hold of them, but I don't know whether they fell pregnant or they didn't fall pregnant. And then the one that I did, I think the last one was the one that I did recently in 2021, and then she was pregnant, and we managed to do it laparoscopically, and she then, I think we did it at about 16 weeks, and then she delivered at 31 weeks. She went into preterm labor, which was refractory to tuberculosis. Next slide. And then basically, these are the numbers. So I'm doing roughly almost 1 to 2. I think the 2019 was the highest number, but also the other thing is with more laparoscopy, I'm doing less and less obstetrics. So maybe that's being reflected in the numbers coming down because I'm not doing as much obstetrics as before. And also maybe because of COVID, there's less numbers. Thank you. Next slide. So in conclusion, basically transabdominal sacrilege is easy, safe and reproducible. And then in the literature, they've been reported that success rate is between 79 and 100% of actually having a viable pregnancy. And then it's also based on careful patient selection. And you need to basically careful patient selection where risk of infection, rupture of membrane. And then there are some areas where sometimes when the membranes are bulging, there are some people who push it and then they do therapeutic amniocentesis so that the membranes don't rupture during the insertion of the transabdominal sacrilege. Next slide. So these are some of the few of the things, but if anyone wants more references, I can provide them. So thank you very much at the end of my presentation.
Thank you so much, Dr. Buma, for such an interesting presentation and for such wonderful work you are doing. I think because it's such a great presentation, I'll also just ask people to ask questions for the next 2 minutes or so, even though we are behind time. So anybody with a burning question, please go ahead. Just right. 2 minutes for questions, yes.
All right. Thank you so much, Dr. Buma, for this good presentation. I need just a clarification. When you are putting trans-abdominal sacrilege by using, for example, a sieve, so you mean to go back again to remove it when it is stem, or you do scissor, or it will just absorb?
No, it's a non-absorbable suture, so it's a permanent suture. So what happens is obviously in the counseling, that's why I'm saying you need to counsel the patient that you will have to deliver by cesarean section. So you only remove it once their family is complete. I think most of the patients still have their, I think I've removed only one, maybe two. The rest of them still want to continue to have children. So when you do the last delivery, that's when you remove it.
Okay, thank you.
Thank you. Do we have any more questions? Maybe just one last one, if anybody, for Dr. Buma.
Can I just ask Eton, is it possible for you to send us a video of the actual procedure? Because some of us are a bit old and we are getting lost a bit with the surgical technique. Thank you.
Yes, now that I have the video, but unfortunately I couldn't upload it to play it. So it's just yeah, I'm technologically challenged. So I need to know how to, I think Grant here and Chipo seem to know their way around. Maybe they will help me to put it together. I have the video, but I'll gladly share it with you.
Thank you. Dr. Ziki, please go ahead.
Thank you for your presentation and to the presenters who've presented before you. Dr. Vuma, I heard you say that you can put a primary cerclage transabdominally. Would this be superior to our usual transcervical cerclages? Because I feel it is, okay, I think it's definitely more complicated surgery, maybe because I don't know how to do it, but what would be the advantage of putting a primary one? For the other indications, I understand that maybe we have failed or it's technically impossible to put it transvaginally. So would it be better as a primary procedure?
One of the things that's obviously coming through is that the patients are getting older. So one loss is one too many. They cannot afford. And some of them have either gone through IVF. So I think we're sort of adapting to the different patient profile, patient expectations. So that is the one issue. And then the other issue is that a transvaginal cerclage, there is always a risk of infection. We have got a permanent foreign body. So the risk of ascending infection is higher. And then in terms of, if you look at one of the advantages that talking about transabdominal, is that there is no ascending infection that is there. There's no permanent foreign body. So they actually presuppose that the outcome is actually better than a vaginal cerclage. Thank you.
All right. Thank you so much, Dr. Buma, for your presentation. Once again, it's such an important presentation. In the interest of time, we will move on to the next presenter. The next presenter is none other than Dr. Joseph Shava. We call him the African gynecologist, and he has really been at the forefront of what we call the Winners Program, which he is going to give us an update on. Now, about Dr. Joseph Shava, he's a Zimbabwean, of course. He holds a Bachelor of Arts degree. He also holds a Bachelor of Endoscopy degree from Belgium. And he is a Bachelor of Medicine and Bachelor of Surgery degrees from the University of Zimbabwe. He's got Master of Medicine in Obstetrics and Gynecology degree. He's a Fellow of the College of Obstetrics in Gynecology of South Africa, and he's a minimally invasive gynecological surgeon, external examiner at the Medical University of Southern Africa for MBCHB, and an honorary lecturer at the University of Witwatersrand in Johannesburg. Dr. Shava, may you please make your presentation, which is an update on the Winners Program. And just confirm you are now available on the platform, Dr. Shava, because I know you're using a different device, so I can't tell which one it is.
Dr. Shava, please confirm the device that you are using and also confirm if I can share your presentation from this side.
Hello, Grant. Is Dr.
Yes.
Shava?
Yes, Doc.
Yes, I am. Yes, you can share my presentation from that side. And let me just video show just now.
All right, that's all right. Tonde, may you please start screen sharing for him?
Okay.
Put it on slideshow. All right, there you go, Dr. Shawa. Yes.
Hello, everybody. And I would like to thank the society for giving me the opportunity to share the recent experience we have had with the training program with the society. Can we have the next slide, please? The next slide. This is just, I don't know how it got into my presentation. Right, the training program, I think if we can give you a small history of what happened to the training program that we currently have. We had experience with the Brazilians who came to Zimbabwe, and they showed us the Romeo and the Gladiator methods of suturing, and this was with the Congress that was the art of and science of laparoscopic suturing. Can we have the next slide? That was the, this is the Brazilian team, and how they showed us laparoscopy, the gladiator method of suturing. Next slide, please. Then we also had in the same, remember the training program that we currently have is actually a blend of the Brazilian experience and also the South African experience. And there was also another workshop that was run with the South African team that came to Zimbabwe and showed how to operate. And it was actually interesting that this was done at Harare Hospital, now Salim Mugabe Hospital, and quite successful workshop that was. And next slide, please. So the specialist, the subspecialty training program, if we do remember in the inaugural conference of August,
Dr. Shawa, we have lost your voice. Dr. Ziki, do you want to carry on with this presentation whilst we try to get him back in the interest of time? Is that okay?
Let me try, Grant. That's fine.
Yeah, that's fine. So, Tonde, can you just continue as Dr. Ziki presents?
I Grant, if you may quickly let Dr. Shawa know that is offline, you may continue talking.
Okay. That's all right.
Ziki, please continue.
So Dr. Shawa was about to talk about the ZSGE subspecialist training program, and the inaugural conference held in August 2018, there were resolutions that were made, and these included, they wanted to adopt the GAZIA training program, which is a milestone, I think, that has been reached. There have been several recruits so far. I think there are 8 of us currently going through this GAZIA training program in Cape Town. We've done the first part, and we are due to go back for the certification in December. Then also one of the resolutions included EMED logbooks, which were to include a section on minimal access surgery. And the society was to approve the level of training and certify trainees, and also to discuss on how to assess candidates on whether they are now competent on laparoscopy. Next slide. So there were timelines that were given, and for these, the 25th of June, 2021 was a timeline set for introducing the points that I've just spoken about, and ZSGE through Prof. Randasara, through Dr. Shava and Dr. Vuma, who've been mentoring, they've introduced the ZSGE, the Gezia training program, and initially, there were 7 candidates who were scheduled for this. I think initially there were about 4, then interest grew, then we grew to 7. I actually thought it was 8 candidates who are now part of this Gezia program. And on the 30th of August, 2021, all the candidates had completed their online certification. So this was actually an online course that you did where they share several videos, and you have to answer all the questions until you get full marks. And I think there were about 12 different, so there are different topics discussed. For example, they'll discuss suturing, they'll discuss energy, they'll discuss, and then you have to go through the questions in order to go through to the next phase, which is the training. So we had all done the certification by the 30th of August. It took long for some people, for most people, because the questions can be quite difficult. And on the 6th to 7th of November, the candidates traveled to Cape Town for practical training. And again, this was through the this was facilitated by Prof. Randasara, and he actually got part sponsorship for the trainees to travel and to stay in Cape Town for about 4 days. And I know that the trainees are grateful to all the seniors who made this possible for us. And in early December, we are actually in the process of planning to go back to write the final examinations. And I'm sure because we don't have our access to the surgical boxes is a bit limited. So I think most of us have actually planned to travel a few days before the exam so that we can train on the stations that we don't have. So we've been using the surgery department though. The laparoscopy box is there to train to suture. And I think this will be when we travel to South Africa in the next few weeks, then we will actually go through some of the boxes that we didn't have access to. So I think these are the timelines, and I think everything is in order right now. All the trainees are going to go to Cape Town in December. Next slide. So the online program I've talked about it a bit earlier. It can be a bit challenging, and it's really up to the student to get on with it, because you cannot move from one phase, from one topic to another without completing and passing. And the pass mark, unfortunately, is 100%. So each time you get something wrong, a group of questions comes again. So it can be quite taxing, and the videos can be about an hour each, 40 minutes to an hour. So they are long videos, and so you have to be really motivated to go through them and to complete them. And I think it helped a lot. Oh, Dr. Shava is back. I'll let him continue. Dr. Shava had gone through some of your presentation, and I had talked to the point where we are planning to go to Cape Town in December. So I'll let you take over with this slide.
Oh, thank you very much. And I think that is the whole idea, that we should be able to continue even in the absence of a problem. The online program, I think, like she said, it was mainly pedagogical and student-driven, where we actually emphasized on motivation, exposition, and we direct activities. And in a few cases where we had imitation, but the main thrust was criticism, and criticism not in the sense of discouraging students, but it was mainly student participation. And we also introduced the idea that we are actually all students, not even us as mentors, we are also learning as well as we go on. Next slide, please. The challenges, I think, the challenges equipment for the and we had to use the Department of Surgery. And unfortunately, the equipment in the Department of Surgery is not and it's mainly, I think the only benefit they would get was just for suturing, but the other exercises were completely different. And the in this transport and accommodation, Dr. Ziki has talked about that. And we also would like to thank the society, which actually organized the support and sponsorship for part of the expenses that the candidates had when they went to Cape Town. Next slide, please. The future is very exciting. The future is very exciting. The exams next year, we are going to have exams in Zimbabwe. And we are actually setting up a training laboratory. Go back. Yeah, we are setting up a training laboratory for the candidates, which will be actually state of the art. And it's what's happening. Go back. Yeah, and this is to build capacity for the mentors and the mentees. And next year we are having 6 candidates. For your information, we are having 6 candidates, and the application can start now. You can start applying now for the positions in next year, and that there will be only 6 candidates. And we are also having negotiations with other associations to cooperate in this training program. And there's been quite a lot of interest in other societies who actually want to see and find out exactly how we are managing to do the training. Next slide, please. Next slide. Am I audible? Am I online, or I am already out of line again?
Now we can hear you.
You can hear me. Okay. So I think, let's go back. The previous slide. Who is moving these slides? Tonde.
Right, everything is up to date this side. I think maybe the internet on your side is slow, but it's up to date now.
Oh, okay, right. So it's this, I just wanted to show you, this is like part of the army of laparoscopy surgery or minimal access surgery in Zimbabwe. That's part of the army. And then the next slide will show us, let's see the next slide. The next slide is just shows the first cohort of 7 candidates who are actually going to be writing beginning of this coming month. So those are the 7 candidates who went to Cape Town, and it's also interesting to note that all of them performed exceptionally well. And in theoretical assessments, they are also performing exceptionally well. Thank you.
Thank you so much, Dr. Shava, for an update on the winners program. Unfortunately, we have run out of time for questions. So what I'll do is, if anybody has any questions to Dr. Shava and even to Dr. Buma and the earlier presenters, just type them in the chat box, and then the presenters will tackle them from there. Otherwise, I think let me give this time to our sponsors for the next 10 minutes, and let's have a working sort of tea break, as we cannot afford to break. So our sponsors, that's Utano Africa, kindly take over. And then when we come back for the next segment, Dr. Ziki will be will be taking over as the chair. So once again, thank you for your attention, and thank you to all the presenters. Enjoy the rest of the conference.
Thank you very much. I'll try to share my screen. Can you see my screen?
Yes, your screen is visible.
Yes. My name is Colbert Kuzai Chinyoa from Utano Africa, which is now the official distributor for Johnson & Johnson in Zimbabwe. I would like to thank the society for giving us this opportunity to reintroduce Johnson & Johnson back into the Zimbabwean market officially, and also present to you the products that we have now in stock, as well as to bring up to pace of the values that Johnson & Johnson has. The first thing that Johnson & Johnson focuses on whenever we are providing our products is the value. But most often, in most cases, we always see that the price tag on the product weighs often more than the outcomes of the patients. And based on that, most of the decisions made in the hospitals so as to cut costs, and thus resulting in the suffering of the outcomes. Here are some instances of the products that we provide as Johnson & Johnson in order to cover that gap and provide sustainable outcomes in the hospitals. We have surgical glues, such as Dermabond, Propane, like the one that is being shown in the picture. These products can actually be used in closing your trocar points and also for your C-sections as well. They are only for external use. We have Dermabond Propane, and we also have Dermabond Mini. Both these two devices are almost the same, and they come in volumes of 0.5 mils and 0.75 mils based on the type of surgery that you are doing. We also have this particular product called Dermabond Preneo. This one comes along with a mesh, and this mesh offers strong support towards the wound. And this is so strong, so much that it can actually be used even in orthopedic surgery, for example, for knee replacement surgeries after they have closed off the wound. And with this product, you can actually then, it can actually allow you to then allow your patients to do to bath at times, and also in some cases, it is actually stronger than skin staplers as well as sutures. We also have products that can rival the popularly used product right now in the market, which is the LigaSure. We, like, for example, you can see that in this instant, we have what we call the InSeal large jaw. This can be used in place of the LigaSure Impact, and its ergonomical design is suitable and allows for easier maneuvering. We have actually studies that show that this product can actually give much stronger seals. And we have the latest version for this model, which is actually very good. We also have both for laparoscopic and open surgeries, and all these are in stock in all the major private hospitals. We are actually working with a couple of government institutions, like for example, in Bulawayo, we have negotiated a deal with UBH, where there will be a old Johnson & Johnson theater, whereby you'll be able to use all these devices. And this allows for a much cheaper experience for the patients, considering that all the other costs, such as hospital stay, etc., will be subsidized due to Zimbabwean standards. So in a system like Zimbabwe, where the healthcare system is under pressure, it's normal for the management to always take short-term cost containment measures. And usually this is done through two routes. And the most common one being taken by most organizations is to do cost-cutting mechanisms. Ultimately, is a negative spiral, and realize that the first thing that procurement team will target are the consumables for the surgery, and this will lead to a much more compromised system, whereby we are offering lower quality products and risking things like revision surgeries in terms when poor products are used. And the other option is the one that we as Johnson & Johnson will try to always focus on, which is a value-based system to guide cost-efficient, informed investment in healthcare. And this has a positive spiral and can ultimately lead to a good health in this society. I will give you an instance whereby we just look at how this was done in the United States, whereby they realized that the cost for most of the procedures were around $5,000 as an average. And this was mostly focusing on the impact or the price, the impact of the price of switchers on the overall cost of the procedure. So the total cost, including the recovery time and everything else, including the theater time, to everything, the medicine and etc., was $5,000. And taking into consideration that 4 switches are used on average in a procedure, it's the average. That means for you to do a surgery, you need to spend, or the patient needs to pay $20 for those switches, which is less than 1% of the total cost of whatever the patient is going to pay. Yet at the end of the day, whenever there's cost-cutting measurement that need to be taken, the procurement always focuses on the consumables, which literally contribute little to nothing towards the overall bill of the hospital. At the end of the day, price is what you pay and the value is what you get. So there is a bridge between price and cost focus and the patient quality focus, whereby we are achieving optimal outcomes over saving money. And this can be done by making best use of the available budget. In another instance, I will show you 2 options that a surgeon can take when doing surgery, whereby in one option, the cost of the medical device, which is the cheaper option, is $1,000. And I'll take the second option, which is the expensive option, because at the end of the day, Johnson & Johnson does not compete on price, but rather on the quality, because we know that when a patient is actually using our products, some of the studies show that it can lead to lesser hospital stays, it can lead to faster recoveries, and in some cases, it can eliminate the use of other, like for example, when you are using Dermabond Preneo, you realize that you don't need dressings, and that have been eliminated from the overall cost or bill. And the second is the cost of the OR procedure, which includes the bookings of the procedure as well as the staff. And then the last one is the cost rehabilitation. And as you can see, when using Johnson & Johnson from this case study in particular, it shows that because of using the Johnson & Johnson products, there was actually $1,000 saving after the procedure. And from a procurement perspective, it's an issue. They'll just look at one aspect, which is the cost of the medical device, not the overall aspect, whereby you look at every stage until the patient has stopped paying for that particular surgery after the rehabilitation. And when you look at the numbers, you see that you can save much more for the total cost compared to the cheaper option at the end of the day. Not to mention an increased risk of revision surgeries, etc. And ultimately, this can lead to a quality of life, productivity, and productivity as well as the freeing up of hospital space. As we can see in some of these private hospitals, we're having a bit of pressure whereby a surgery that's supposed to be taking 4 hours to 5 hours can actually go from 8 hours, maybe to 10 hours, eating up the time taken for other surgeons to actually book. So for us to achieve this dream that Johnson & Johnson has, all the stakeholders should be in scope. And this includes you as the medical professions, the procurement officers, the nurses, the hospital managers, and the insurance companies. We have been trying to engage with the hospital managers in different hospitals, both government and private. And we have been starting to engage with medical societies as well, and doing some trainings on OR nurses. And also we have been interacting with procurement officers as well as some doctors. And we hope at the end of the day, we'll try to see that value is more important over cost, even though we are in a base of pyramid market whereby most people cannot afford the type of healthcare that we are providing. Thank you very much. Have a good day.
Thank you, Dr. Ziki. Now you can take over.
Thank you, Grant. Thank you to the presenters who have just finished the first, our morning session. And I'm aware that we all had a working tea break in order to allow us to catch up with our time. Our second session is going to be done by 3 presenters. And the first presenter will be Dr. Michael Nyakura. All of us are aware of, know Dr. Nyakura. He trained in Zimbabwe, both his undergrad and postgrad. So he graduated with the University of Zimbabwe. Right now, he is based at Victoria Falls Hospital, and he's the Mat North Provincial Obstetrician and Gynecologist, and he's also a clinical mentor. His special interest is in gynae endoscopy and gynae oncology. Dr. Nyakura, I can see your presentation is already up. Please go ahead.
Thank you, Dr. Ziki, for the kind introduction. Good morning to you all. I'm going to present on laparoscopic suturing. Dr. Nyakura, as Dr. Ziki has already indicated, and based at Vic Falls Hospital in Mat North. I hope you can all hear me.
We can hear you, Dr. Nyakura.
Thank you. I have no disclosures to make. here's the outline of my presentation. I'm going to discuss on instrumentation, the suture materials that we use in laparoscopic suturing, ergonomics, tissue approximation techniques, and knot formation. So in terms of instruments, probably one of the most important instruments that we need to consider is the needle holder. There are different types of needle holders in the market. They can behave, you look at the jaw, it can be straight or curved, and you opt for the instrument or for the needle which gives you the desired angle for suturing. So you want to look at a needle that will give you an angle of 90 to 135 degrees. Here are some of the needle holders in the market, and the choice is to be, this needle holder should give you a better ergonomic handling. So the handle, preferably the straight handle compared to the pistol grip. And then the shaft should be glare-free, and the jaw, as I have already indicated, preferably should be curved in order to be able to be used for driving the needle. So the ergonomic handles are what are preferred, and this picture is already showing us the same. In terms of instruments, again, we need the knot pushers. This is for the in cases where we are doing extracorporeal knot tying. I will discuss on this later on. Then the needle, there has been transformation from the use of the straight needle to the skin needle, and now they have circle needle. So the straight needle was noted to be easier to introduce in the abdominal cavity, but it gives us just one-dimensional suturing. So it was a bit of a challenge. The skin needle sort of tried to intervene in terms of giving us a bit of dimension, but still the depth was lacking. The use of the curved needle was then noted to give us a two-dimensional aspect, which will be able to drive the needle through and out of the wound. In terms of the suture material, absorbable sutures, it all depend on the area where we are working. So absorbable suture, probably Vicryl, was favored for most gynecological procedures. Non-absorbable sutures are also used. And then in terms of the length of the suture, for intracorporeal suturing, we need a short length suture, 15 to 20 centimeters. And then for extracorporeal suturing, it should be about 90 centimeters up to 110 centimeters. So we need a long suture. So in order to make suturing easy, we need to consider a lot of aspects: the position of the camera, the position of the surgeon, the position of the ports, accessory ports, and even the monitor itself. So the surgeon, so we are comparing two positions that the surgeon can find themselves during the laparoscopy. Ideally, the patient should be in a low lithotomy position with arms by their sides. And then the surgeon should be able to look at the monitor with a down gaze, as opposed to the condition in B, where the surgeon is facing upwards. This can put a strain during the procedure and make the surgery a bit difficult. The other thing that to note is also the position of the arms, the elbows. So they should be close to the body at an angle of about 90 to 120 degrees. The triangulation that I was talking about, we have the surgeon, the camera, the patient, and the monitor in a straight line. This will allow the procedure to be completed without putting a strain on the surgeon. I'm being blocked here. Anyway, so the different types of tissue approximation. So there's laparoscopic, extracorporeal, and intracorporeal knotting. And then other ways of achieving tissue approximation include what
Hello,
Johnson
Dr.
and Johnson
Nyakura?
did. Hello, Doc. Are you able
Let
to
me
hear
try
me?
and get hold of Dr. Nyakura. Please excuse this.
I can hear you, Dr. Ziggy.
Please continue, Doc.
Dr. Nyakura, you may continue with your presentation. Let me get hold of Dr. Ziggy.
Hello, Dr.
Okay, we'll be trying to get hold of Dr. Nyakura right now. He can hear me, but we can't hear him. So we'll give him a few seconds to turn off his mic and on again.
Can you hear me now, Dr. Ziggy?
Dr. Nyakura, we can hear you.
You can hear me. Thank you.
Yes.
I think my slides had moved.
Maybe I can ask Dr. Because Dr. Nyakura is trying to say something. I'll ask Dr. Mrevanema to continue with the presentation for now. Grant, if you would please come in.
Hello, but I think the team can hear me.
Yes, we can hear you clearly, so it's fine. I think you can just continue.
All right. Thank you. So in most of the literature, if you read on literature on laparoscopic surgery,
Oh, I'm getting the message that everyone can actually hear both of us. So Dr. Nyakura, please continue whilst I start again.
All right, that's okay. So there's an issue of the learning curve, and which is described as steep. But from the training that we've been receiving, we have noted that probably the approach would be incorrect. And once this approach is addressed, everyone should be able to achieve the skill in laparoscopic surgery, especially suturing. What are the differences between laparoscopic surgery and open surgery? So,
share your slides, Dr. Nyakura.
All right. Are you able to see the slides now?
Not yet.
All right, let me come out of this. Now.
Just stop sharing and then start sharing again.
All right, let me do that. Can you see the slides now?
Yes, it's coming up now. Yeah.
All right, thank you.
So you can go to your slideshow and then continue.
All right. All right, so I was just describing the differences between open and laparoscopic suturing. So in open surgery, it's fast. The ergonomics are optional. You can approach the suturing in almost any direction. However, in laparoscopic suturing, the process is a bit slow with the magnification effect, and you need to establish choreographic movements. The ergonomics, very critical. Triangulation and the angle of manipulation during the suturing. This is what I'm talking about. You are looking at images in a two-dimensional aspect. You lose the depth of perception, and there's also no tactile feedback during laparoscopy. So you then need to learn the proper steps in approaching suturing. Introduction of the needle, the loading of the needle, which is probably the most difficult aspect of suturing in laparoscopy. Then the penetration of the tissue, manipulation of the thread, and knotting. And the aim of suturing is to achieve the perfect stitch. Introduction of the needle into the abdomen, you can be, if you are using the 10mm port, you can directly introduce the needle through the port. If you are using a 5mm port, then you need to use the backload technique. And if it's through the abdominal wall, like with the straight needle, you can just introduce it directly. The moment the needle is introduced to the abdomen, you really need to be careful. It should always be in the view. The trailing needle is safer compared to the needle which is in the needle holder. The tips of the needle holder should always be in view, and they should never cross each other. This is probably the most difficult part, and there are so many difficult techniques that have been designed to assist in loading the needle. We have the lay on tissue technique, where the needle is picked up by just a nudge on the tissue, and the needle is then loaded onto the needle. We have the core technique, which uses the two needle holders, Wattier's technique and the twist technique. The needle must be positioned correctly in the jaws of the needle holder, ideally grasped in the right orientation by the tips of the jaws. And this should always depend on the person, whether the surgeon is right or left-handed. The key elements in achieving this is the position of the needle to the tissues, the angle of approach of the needle holder, and the pickup actions. And all these elements point to achieving the perfect stitch. Then adjustments of the angle can be made using any of the techniques: needle manipulation, use of the surrounding tissue, thread manipulation, and bow and arrow techniques. And then the orientation of the needle, whether it's facing the left or the right, can be achieved using the flag maneuver, grinding coffee maneuver, and the auto-valen maneuvers. I'm not going to go too deep into those maneuvers, but as you can see in the needle position, it needs to meet the needle should meet the wound at right angles. It should come off the needle holder also at right angles and slightly obtuse up to about 135 degrees. And then you can manipulate using the techniques that we have already mentioned. Then driving the needle through the tissues. Again, the needle at right angles is then appropriately driven into the first point of entry. And the driving is basically a rotational movement as compared to a translational movement. And usually, once the needle has been loaded correctly into the needle holder, this should be an easy technique. And then the next part on suturing, it looks at the knot formation. And there are so many different aspects in terms of laparoscoping surgical knots. Intracorporeal, extracorporeal, and then there are other types of knotting. I'm going to start by looking at the intracorporeal knotting. This is one of the most challenging aspects of laparoscopic surgery. There's loss of depth of perception and tactile stimulation, as we have already mentioned. And there are different methods that have been designed to overcome this. The Smiley, cinch, expert, the gladiator technique, and the noodle techniques. I'm not going to be able to talk about all of this, but I'll zero in on the expert techniques. You need to be aware of the passive and the active role of the needle holders, the formation of the initial C, the natural bias of the thread, choreographic movements that are needed with the needle orders, economy of motion, execution of knots on the surfaces of the tissue, and you need to be able to use both hands. The expert knot is a precise choreographed set of actions which follows steps, which initially you need to form a C, and then a reverse C, and then you repeat the same until you have completed the surgical knot. It's better demonstrated in this flow of pictures. So initially, after entry into the wound, you form a C, and then you make your 2 throws, go and hold on to the short end, and then pull the throws and make your knot. So that's the initial surgical knot. And then you pull and tighten the initial knot, and then make a reverse C, go on to grasp the short thread and pull. So you have 2 throws already. Then you go back and form the initial C, almost the C as the initial knot was being formulated. And then you grasp onto the thread and then tighten your knot. The last picture there on the bottom, on the right side, is showing the 3 knots as they were formed. Extracorporeal knotting is probably easier because the suture is formed externally, driven by a knot pusher, and then secured inside the patient. It's probably applicable to most tissues, except on soft tissues, where we prefer to use the intracorporeal knotting. Another image just showing extracorporeal knotting. So many techniques used to make the extracorporeal knot. Now there are new methods of delivery, of making the sutures, and barbed sutures are one of those. And I tried to put a video here. I hope it's going to play on the barbed sutures. It's a 2-minute video.
Dr. Nyakura, I'll give you about 3 more minutes.
Sorry, Dr. Ziggy.
I'll give you about 3 more minutes.
All right, that's fine. I'm almost done. Can you hear me?
Yes, yes, we can.
Okay, okay. I'm realizing, looks like the video is not playing. So basically, the barbed suture, it tries and makes suturing easy by avoiding the use of knots. Having noted that making of knots is a bit difficult to many surgeons, this barbed suture can be used open and even in laparoscopy, and it is associated with shorter operative or surgical times. However, it has its own complications, and there are few reports of wound dehiscence after barbed suture. So we really still are learning and improving in terms of suturing in laparoscopy. And many more techniques are coming, include the Da Vinci and robotics.
Thank you for your presentation, Dr. Nyakura. And I apologize for the glitches. Some of them are really beyond our control, but I think we managed to catch up despite these glitches. I won't allow questions at this point. Let's hold on to our questions or put them in the chat box and we'll attend to them later. Allow me to present our next presenter. It's Dr. Mzamiri Tavaziva, who's the clinical director of Waikato District Health Board. He's a consultant obstetrician and gynecologist and an advanced laparoscopic surgeon. He qualified at the University of Zimbabwe in 1998 and MRCOG and RCOG in 2007, and another PMETB RCOG in the UK in 2011. He has a certificate in healthcare law and ethics from the University of Dundee, and this is in 2012, and a certificate in advanced gynae endoscopy from the University of Surrey in 2016. He also has the FranceCog and ANSCOG in 2018. He graduated from the UZ in 1998 and did his resident medical officer rotations at Mpilo. And after this completion, he then worked as the hospital medical officer in Obs and Gynae. He sat and passed part 1 of the College of Medicines in South Africa. And after that, he relocated to the UK in 2003, passed membership exams in 2007, and completed a specialist training in 2011. And over the last 10 years, he has moved from an initial focus or special interest in oncology to be a minimal access surgery specialist. And after working in the UK as a specialist, his family then moved to New Zealand for better work-life balance in 2017. He was appointed as the clinical director for gynecology in Waikato in 2018. He's the unit lead for gynae oncology in Waikato. He has a passion for surgical training. He's a faculty chair for the Midlands Endometriosis Advanced Laparoscopic Training Program and also an educational supervisor for Australasia Gynecology Endoscopy Training Fellowship for Advanced Minimal Access Surgery with an emphasis on endometriosis surgery. He's a consultant for Johnson & Johnson and he has received support from the industry partners for educational activities, running workshops, meeting with Karlstorz, Ethicon, Hologic, Applied Medical and Medtronics. His wife is a nurse at Waikato Hospital, and she also trained at Mpilo Hospital, and they have 3 children together. So, Doctor, please carry on with your presentation.
Sorry, thank you very much. I'm trying to screen share, but I can't seem to get my files coming through. Can you allow me to screen share if possible, please?
Dr. Mzamiri?
Yes, can you hear me? Can you hear me?
Yes, we can hear you.
Dr. Mackenzie is here. I might need to move on to Dr. Mackenzie whilst we wait for Dr. Mzamiri to log on. Dr. Mackenzie, can I'm do that?
Here. Can you see me?
Dr. Mackenzie, I just needed you to acknowledge that you're ready.
Dr. Mzamiri, please confirm the device you are using so that we can grant you permission.
Okay. Sorry, I have logged on through. All right, I will show you through that. That's me there. I don't know if you can see me. I just switched on my video.
Okay, please go on. You can now share your screen.
All right, I will try and see if I can. Okay, thank you very much. That's better. Okay, good. Thank you very much for the introduction. I will start with the presentation. Can you hear me?
Yes, we can.
Thanks. So this is more of a procedural discussion, and I will focus on laparoscopic uterosacral vault suspension. For disclosure, I think Dr. Mackenzie is a Eurogyne, is going to be smiling at this, because this is an area of interest to him much more than me in terms of uterosacral vault suspension. But we've expanded the repertoire of laparoscopic work and in terms of what we can do with it. And I think that there's lots of things that we can do with laparoscopy in terms of managing urogynec problems. So this is where I work, and my disclosures are pretty much I've stated them before. The way I'm going to approach this is just a basic introduction of the procedure itself, then talk about indications and patient selection, and then a description of the procedure. A couple of videos that we're going to go through and be able to identify a few of the surgical steps that we take for this procedure. Then look at some of the evolving approaches or alternative approaches that are available, and just a brief discussion around that. So feel free to stop me if I'm not clear and just let me know. So to start off with, I'm just going to go through this video as I discuss the procedure. Thank you very much for the previous speaker who mentioned about suturing and the approach. So this is a video just talking about laparoscopic vault suspension. And the first thing that I want to talk about is the issue of patient selection. Now, the indications are pretty much similar to what you would do for any particular procedure. For this, you're looking at patients who have uterovaginal prolapse. Specifically, we're looking at an apical defect. If you're thinking of a stage 3, stage 4 defect, apical defect, then you're saying, hey, this is the kind of patient that we would want to treat. This allows for all comers. As we know, the risk factors that lead on to prolapse are fairly well known. You're looking at elderly patients, you're looking at Caucasians, you're looking at patients who've had multiple pregnancies, you're looking at patients who've had operative deliveries, you're looking at patients with chronic cough, chronic constipation. These are your risk factors. Once you've identified your patient, then you need to think of the surgical approach and how best to tackle that. For this particular case, this was a patient who was in her 50s, who was coming in with problems of uterovaginal prolapse, but also had at that time atypical hyperplasia, and therefore hyperplasia, and therefore needed to have the uterus out. The surgical approach that I took for this particular case really involved the initial hysterectomy, and at this stage, what you're seeing is suturing of the vault. I'll pause this for a moment just to identify a couple of aspects. Number one, prior to taking out the hysterectomy, took time to identify uterosacral ligaments here. This is a simplified approach in the sense that you just want to see where you place the suture, and at the time of the hysterectomy, I had identified where my ureters were passing through in the space and also further laterally on the other side. Put marker areas and just separated the uterosacral ligaments quite clearly. Thereafter, went ahead and then looked at doing the complete hysterectomy laparoscopy, then proceeding to choose suture for closure. The suture for closure that we're using is the barbed suture that just been talked about. We'll do a running suture. And in this case, I was doing a 3-portal laparoscopic surgery, so with no assistant, just working along on my own in that sense. So for this particular approach, we're aiming just to close the vault from right to left, and just with a clean operating field coming along to identify the angle, and then moving on to the uterosacral ligaments. There are various descriptions for this procedure, and this simplified technique just allows the clinician to be able to work comfortably in under direct vision. One of the things you can see is that the vault itself is fairly mobile. It's moving, and you can quite see that when pulling it up, it's coming up quite high. You know, that's just an indication of how relaxed the vaginal tissues are. This particular video, just slightly speeded up, but in total, this whole procedure takes about 8 minutes or so. And you can see the ease of the whole operation, where if you can close the vault, do a suspension procedure within that time span, it means then from a time perspective, it should take just the same amount of time as you would do a vaginal hysterectomy with a suspension procedure. You may ask us to say why this particular approach, if you can do this vaginal, why not then just do this vaginal instead of laparoscopic? For this particular patient, we needed to take out the tubes as a wrist retraction procedure, but we kept her ovaries because of her age. She wanted to keep those. Now, at this step, having mobilized the left uterosacral ligament, then use the suture to move along to the other side and bringing everything close to the midline. Everything is being put under reasonable tension, and every step of the way is just trying to bring it closer to the other uterosacral ligament. Once you reach a point where it's fairly close to the other uterosacral ligament, you will notice that I'll once again go and identify the same point that I'd marked earlier on at the time of the hysterectomy, and use that as my point of insertion. This is a fairly simplified technique, and which allows ease of operation. I will show you another video later on from some authors that looks like it's doing a different way, but once again achieves the same result. So from an operating perspective, you can see that this can be achieved in a relatively let's say straightforward aspect with minimal blood loss in terms of the suturing. Just coming on to the end of the procedure now, and reaching a point where you're just anchoring the sutures right in the midline, and you can see the bolt pulled up and attached once again to the uterosacral ligaments. So in a way, that's a fairly simplified procedure. So what are we talking about? Why do we have to do that? Well, we do that because the uterosacral ligaments are fairly strong structures. They provide a very strong supportive tissue for vaginal vault suspension, and that mimics the natural support of the pelvic floor. And we know that uterosacral plication, which is what we've just done, is when you suspend this high on the uterosacral ligaments. Its use following hysterectomy has been shown to be effective in preventing and treatment of vault prolapse. So what are the steps? All of the steps really look at saying, hey, we need to identify the uterosacral ligaments at the time earlier on. So at the initial point when you're doing a hysterectomy, we'll identify the uterosacral ligaments, identify the part of the ureter. And in some instances, you may actually have to do a uterolysis so that you release the ureter and they don't get incorporated in the uterosacral ligaments when you do the plication. Second step is that you want to mobilize uterosacral ligaments and do uterolysis, and then you then move on to the third step where you do the vault closure. Once you do the vault closure, you then do the uterosacral plication as indicated in the video that I've shown you. This particular diagram just demonstrates some particular aspects regarding uterosacral vault suspension. By lifting up the superior aspect of your vault, you can notice that this straightens the anterior wall, this straightens the posterior wall. You, more often than not, when I've done this procedure with the patient with vaginal prolapse, where you've got cystocele or rectocele, there is a reduction in both the cystocele and the rectocele to the point at times that I don't need to do further repair. And this is mainly due to that significant aspect of plication. And there are different levels where you can do the plication. You can do the plication as proximal, or you can do a high uterosacral vault suspension. I'll show you a video demonstrating this. But the principles, once again, and the steps that I've mentioned, first and foremost, you want to identify your uterosacral ligament and the ureter. You want to mobilize uterosacral ligament if possible, and also carry out a uterolysis so that you can clearly see where your ureter is sitting at. You then close your vault, and then thereafter carry out uterosacral ligament plication, and thereby suspending your uterosacral ligament. Studies have looked at this and answering the question is as to, does this work? Is this comparable to what we've done before? The urogynec surgeons might come along and say, hey, you can do a similar procedure vaginally and you will achieve similar results. And that's true. When you look at studies that have compared uterosacral ligament suspension and sacrospinous ligament suspension, it's shown equivocal results, with some studies showing no difference and others suggesting that uterosacral vault suspension is superior. Hasby et al. Found that uterosacral ligament is superior to sacrospinous ligament fixation regarding reoperations in the anterior and apical compartments. So there's some evidence to show that this particular approach would be superior than sacrospinous fixation. Unfortunately, it's not other authors have found that these in terms of success rates and patient satisfaction, these approaches were fairly similar, and this is consistent with the large optimal study that is looked at a large data set. So what should we do? Well, there are a few things that may sway people in the favor of doing laparoscopic uterosacral vault suspension. And the aspect of being number one with laparoscopy, then you can carry out concomitant adnexal surgery. And therefore, if you're aiming for risk reduction by laparoscopy or oophorectomy, and this may actually determine your surgical approach. There are limitations in just doing a vaginal approach and in terms of getting your adnexia and getting a good oophorectomy or a subinjectomy. There is an argument that with the advance in vaginal surgery where V nodes is coming into play, this procedure can be carried out vaginally with no cuts on the tummy. But here, at this stage, with the majority of surgeons carrying out laparoscopic work, this offers an advantage in comparison to vaginal approach. I'm just going to show you, hopefully this will open up, if you can let me know in a moment. Can you see this particular screen with the video? Can you hear me?
Yes, we can.
Can you see the video on high uterosacral suspension?
Right now on the screen, there's no video.
All right, I will just open it up in a moment. Okay, so this is a video showing a different approach, fairly for similar indications in the sense that the patient with vaginal prolapse who underwent laparoscopic surgery and just demonstrating where port sites would be, and similar to where you put your port sites in a standard operative procedure. And in this particular case, the same principle was saying that the first step, you really need to identify uterosacral ligaments and identify your ureter, being able to carry out uterolysis. And the rationale of this is that you want to free up uterosacral ligament and identify it quite clearly. So this particular approach is more involving, that there's a lot more dissection and there's a lot more freeing up of the structures on the pelvic side wall. So as a surgeon, I would say you have to be comfortable in doing a decent uterolysis, and you have to anticipate that there will be some bit of bleeding on the pelvic side wall with this. So the key to this is being able to open up that lateral aspect and being able to identify clearly where the uterosacral ligament is and not cutting into the uterosacral ligament. With this high uterosacral ligament suspension procedure, this particular step is done prior to carrying out your hysterectomy. As I mentioned, this is a bit more elaborate. So for most of my cases, I would do a simplified approach, like the one that I've just demonstrated in the first instance. Once again, this particular surgeon using harmonic to really open up the planes and then carrying out the hysterectomy. Once the hysterectomy is done, the high uterosacral ligament suspension is then done in a similar manner. In this case, the vault has been closed, and then using for this particular technique, a dissolvable suture, grabbing the uterosacral ligaments quite high up, and using the same suture coming on to then attach that to the anterior aspect of the vaginal vault. So there's going to be two bites of the uterosacral ligament to get good tension, and clearly identifying where the ureter is and having more mobilized that away. It's quite easy to see how as a procedure, this makes sense. Then moving across to anchor that to the right side of the vault and space in that uterovesical space, they're taking 2 bites on the vault and then bring them right across the midline. With this particular technique, you need to be comfortable with intracorporal suturing and being able to get your needle positioning very well. As demonstrated by the previous speaker, talking about your A, B, and C points and being able to load your needle comfortably. And so it's important to practice. I can't emphasize more the importance of doing simulation and taking time to use the simulator so that you get comfortable in suturing. But the difference for me as a surgeon came through when I started suturing comfortably, and being able to do that makes a huge difference as a laparoscopic surgeon. In this case, to the left side now, and once again, the ureter has been moved away, and therefore the surgeon is quite comfortable taking uterosacral ligaments quite nicely. And then this is a high uterosacral ligament suspension. Now you'll see when tension is applied, how the tissues will come together. This particular surgical technique involves at least 2 surgeons and three operative ports. So with this much tension, you can see the amount of lift that is generated on the uterosacral ligament. And once that's done, the aspect of now then creating a knot such that you have that bit of tension, and you're using your assistant to hold the knot and make sure that you tighten it just really comes closer to the midline. You almost form a shelf, as you can tell, and that helps to give that bit of extra support that is needed. So in a way, as you can tell, this sort of demonstrates the steps that I've spoken about. And in this case, being a high uterosacral ligament ball suspension, it's one way you really need to carry out the dissection appropriately. You can't do this approach easily vaginally, and most of the vaginal approach, you're actually doing a proximal suspension and not as much of a high uterosacral suspension. However, this can be achieved very well with the venous procedure. I think Elliot McKenzie will speak more to that. Hopefully in his talk, he will mention that you can now do this particular procedure vaginally, but utilizing, once again, laparoscopy through the natural orifice approach. So yeah, so this is the high uterosacral ligament ball suspension procedure that's associated with that. So hopefully, I trust this has shown you the kind of surgical approach and the surgical steps that you can take in carrying out this procedure for uterovaginal prolapse. And once you're done, you can see now that there's good support that has been achieved. And again, lots of demonstrating the techniques of intracorporal suturing and knot tying. And yeah, so important to practice this particular technique, just knot tying and suturing that will, as I said, make a difference in terms of the evolution as a laparoscopic surgeon. So good support achieved throughout. Right, so that's the slide just demonstrating a different approach in terms of doing that. And yeah, so I'll take it. I trust we don't have enough time to take any questions, but that's the end of my short presentation on laparoscopic uterosacral ball suspension, the surgical approach, some of the indications, and the steps that you need to be mindful of. I hope this has been useful and beneficial for you all. Thank you.
Thank you so much for that wonderful presentation, Doc. And yeah, please stick around. We will have questions for you at the end. I'll quickly move on to our next presenter. And our next presenter is Dr. Mackenzie. He's from Neuso, Mondoro. Now he lives in Dunedin in New Zealand. He's an expert trained in gynecological surgery, focusing on vaginal and keyhole laparoscopic approaches to fix pelvic organ prolapse without a mesh. And he is fellowship trained in New Zealand and has advanced laparoscopy courses from Australia. He regularly updates his knowledge in women's health and surgery from literature and workshops locally and abroad, and collaborations with leading experts in the field of gynecology, urology, and colorectal work. He researches new approaches to the treatment of bladder problems, and he's also a specialist in public service. He's a teacher in medical students at the University of, I hope I got that pronunciation correct, Otago. And he's a supervisor, trainer of specialist obstetrician and gynecologist for the Royal Australasian College of Obstetricians and Gynecologists. His qualifications, he has a FranceCog offered by RANSOG, diploma in OMG, certificate in urodynamics, and MBCHP. He's also a part-time farmer who enjoys working the land. Dr. Mackenzie, may you please start sharing your slide and you can start your presentation.
You are unmuted by host. Hello, guys. There may be a bit of an echo there. Can you hear me?
Yes, we can. We can hear you very clearly.
Now it's gone live.
You can go ahead, Doc. We can loudly hear you. Please confirm you are not using two devices. That's the only reason that you might have an echo.
It's gone. I was looking at it all along just now.
We can hear you, Doc.
You can see my screen?
Yes, we can see your screen now.
Can you hear me?
Yes, we can hear you.
Oh, you can hear me. Okay, that's fine. Sorry, guys. Sorry for that technical thing. My name is Elliot. Yes, I'm in New Zealand, in Dunedin. I work at the Southern DHB Hospital and for Mackenzie Gynae. I've been asked to give an introduction on V-nodes. Really, it's just going to be like on the surface. And I'm thankful for Applied Medical for coming through with helping with this presentation. So disclosures, none. Why is it showing that? So natural orifice or V-nodes is vaginal natural orifice transluminal endoscopic surgery. The question there was, what is it really? We know that natural orifice surgery has been around for a long time, and probably dates way back to 120 AD when the first vaginal hysterectomy was performed. And then things went a bit further around 1865 when cystoscopy was invented, or the endoscope was invented. But the first proper natural orifice transluminal endoscopic surgery was not until 2007 when a cholecystectomy was done. And now this has gained popularity among lots of different surgical specialties, and recently with gynecologists. And its utility really is that it gives better visibility to the pelvis. It allows more precision when you're operating compared to just doing vaginal surgery. And to the patient, it gives the benefit of less pain, less blood loss, they recover quickly. And I think the biggest benefit for patients really is that there's no scars on the abdomen. And the question is, what's the point? We already have advanced surgery in terms of laparoscopic surgery. So why bring in another technique? Some clever guys have looked at this and they've demonstrated that V-nodes really is not superior, is not inferior to laparoscopic approach from the abdomen. This is from the Halon trial by Jan Beckland in Belgium, the guy who's been at the forefront of pushing V-nodes in the Western world. We know that women were able to leave the hospital much quicker as a day procedure after hysterectomy. And overall, really, there's short stay in the hospital. And the conclusion there is what I've already mentioned too. And this has recently been followed up by the same team with regards to getting the adnexa for benign cases, that is getting your tubes and the ovaries, and came up with almost the same sort of conclusions. The primary endpoint for the notable trial was that there were no conversions. So that meant if you started off with the vaginal approach, there was no conversion to abdominal approach. Or if you started to abdominal approach, there was no conversion to well, open surgery. Granted, there is a trend towards more adverse events when V-nodes group in the V-nodes group, and that probably is related to the fact that most people who do laparoscopic surgery do not have a lot of practice with regards to vaginal approaches, and we'll touch on that a little bit later. So now lots of papers have come up talking about V-nodes from different sectors, Asia, Europe, America. And I think the reason why V-nodes really has grown is because the equipment that is being used now makes it much easier. We have a platform that allows us to sort of do this surgery much better compared to where we started from. And those were the sort of initial improvisations in terms of putting ports into the vagina, what is called the poor man's V-nodes, but where ports were put through gloves, and then being able to create pneumo that way. The required skill set, I think, from V-nodes is that you largely need to be a vaginal surgeon, and not so much in terms of laparoscopic skill. The thing there being that the learning curve for doing your anterior and posterior colpotomies is a bit steep, but once the operating platform has been placed, really, say for doing a hysterectomy, it's a straightforward procedure, which is equivalent just doing a paper scissors cut, as we shall demonstrate. So I've staged a couple of videos together. Actually, it's videos from 2 patients for the venous approach. And then after the videos, we shall move on to a practical simulation on venous. So this is the hysterectomy part after the geoform platform has been placed. And as you can see there, the anatomy is kind of reversed, but I believe that this is the way that we should always view the anatomy, not the opposite, top to bottom. And you can see there that you do not have the headache of getting a second assistant to manipulate the uterus. You have done away with the corpotomy cup, and once you're in, it's just sealing and cutting. So this case, this part is operating on the patient's left side. And once you get to the infundibulopelvic ligament, you may seal or may leave that incompletely cut so that you maintain the orientation of the uterus when you do the opposite side. Yep, and that's the final seal. And you now move over to the right side, and the uterine artery pedicle has already been taken. And as you can see there, the anterior-posterior orientation of the uterus is maintained. And you can also see clearly the pelvic side wall, that hemostasis has been achieved. And this is done in steep Trendelenburg, recommended about 30 degrees. And you can see that the bowels are away. But it's important to know that when you're sealing there, the tip of your sealing device is the blunt point. So you always have to sort of keep an angle where you can see where you are cutting. So that part completes the hysterectomy. You can see the bladder there anteriorly. The platform had blocked the catheter, but it didn't really get in the way it maintained our vision. This part is now moving on to identifying your pelvic side wall, particularly to pick up the uterosacral ligament. And we are demonstrating the path of the ureter there and the uterosacral ligament. And equally, this allows us to do a high uterosacral ligament corpopexy. And the anatomy being in the right way, I think that this venous approach makes it much easier actually to do a high uterosacral ligament stitching or suture. So that shows the first stitch placed on the right side for this patient. So in our approach for uterosacral corpopexy is to put 2 non-absorbable sutures quite high or above the ischial spine. That's placement of the second suture. And moving on to the left side, the anatomy there is clearly demonstrated. You can see from top to bottom the ovaries which have been kept for this patient. And you'll see the ureter, vermiculation of the ureter that we are demonstrating now, and then the uterosacral ligament. And that's also prominent or made prominent by applying traction to the uterosacral stitch that you take before you place the gel form platform. And I think that portion does demonstrate the rotational bite that is required with the needle. And of course, you need to take your time to do this safely. The gel form platform has got 10mm ports. So all these needles are front loaded. Under tension of the first stitch, we are applying the second one. And that's a permanent ethibond stitch, which means that at the end of the day, when the vault is suspended, these sutures are buried. I tend to use a mix of ethibond and absorbable sutures as well, because the absorbable suture aids in closing the vault, and they tend to be insurance as well when in some cases the sutures break under tension when you're tying them down. So that demonstrates both sides, stitches in place. And at this point, you then move on to remove the gel form platform, which we shall demonstrate. And at the end of these procedures, I always do a cystoscopy with contrast to demonstrate that the ureters are indeed intact. This next section shows another patient that clearly demonstrated anatomy. So this is before the hysterectomy is started, showing a uterus that has got an anterior fibroid. You can see your bowels, your falciform ligaments clearly. Your obliterated umbilicals. And at the level of the sacral promontory, you can see your external iliacs, the ureter where it crosses the vessels. And shortly, we'll also demonstrate the appendix. Hence, natural orifice surgery has been utilized by the general surgeons to perform appendicectomies. You can see the sacral promontory clearly in your face there, inviting for sacral corpopexis if you are inclined towards that way with mesh. Still demonstrating anatomy. When we get to the uterine view, it does give you that paper scissors approach that I was talking about. So for this uterus, only the uterosacral ligament pedicle has been taken. You still have your uterine arteries, you have your cardinals, and the infundibulopelvic ligament pedicles. So that has progressed to the first part of the hysterectomy on the left side and moving on to the right side. Completing the division of the uterus on that side as well. And once that has been done, you can also see the anatomy clearly demarcated, and that is also with tagging of the uterosacral suture. That being the uterosacral ligament, the ureter, the ureter on its path, and that's a placement of the first suture for uterosacral colpopexy. And that's suture placement on the left side. And in this case, there was no need for dividing the interligament ureter space, because you can demonstrate that clearly the ureter is out of the way. And that view does show sutures placed on both sides. A second suture has been placed higher up. That's placement of an absorbable suture, which is the insurance really when it comes to vault closure once the suspension sutures have been attached and are tied down. The advantage of this suture is that it's put through and through. That is, you actually leave it hanging in the vagina and tie it down at the end of the case. And again, you perform cystoscopy with contrast. So that sort of ends the video presentation. I'll hand you over to Melissa McKendrick from Applied Medical to demonstrate the job. Yeah, you just use that camera. Okay, yeah, that's fine.
I'll use this one first. Hi, everybody. So, let's see, can you guys see me okay? Okay, there we go. Great. All right, so what I'm going to do is I'm going to show you the VPath, which is what Elliot has been using in his cases that helps create this pneumo space in an endoscopy space. So this is what the cap looks like. And this is what goes down, and it's a gel cap, silicone cap that you're going to be putting trocars into. Okay, it's like that. And we generally put 3 in. And you put you have smoky vac as well as suction port or pneumo ports in there if you'd like. And then you just pop these in and you basically slide the gel over it. And you really have, no leaking during your surgery and creates a nice pneumo space. So compared, I know Elliot showed you guys the early days of when they were doing this natural orifice surgery with the glove and the trocars on the glove. And this is really what we've developed after a lot of feedback from the surgeons and a lot of help from, you know, Jan worked a lot on it, and we had surgeons in Asia as well that were really pivotal in getting this off the ground. So get your 3 trocars in. And so now you have, it is single site surgery, but because you're able to, again, use the natural orifice, you'll see you do have really great visualization. So we have, I don't know if anybody's familiar with the Alexis out there, but this is what we're using. So you have a very flexible ring here that you're going to insert and into the anterior space as well as the posterior space. And you kind of put it completely around the vagina, and you kind of put it into a C, if you can see that, and slide in to the anterior space first. And then this is going to go into the posterior space. And through the middle, you're going to have the cervix and vagina coming through that. Once this is placed, you roll this down twice, and only twice. If you're used to using the Alexis, you're used to wanting a lot of tension, but you only want it twice. Put the cap on, and there you go. So now you've created, get it all the way in there. Sit in all the way. Slide it. Slide it under the lip.
Yep. Okay.
There you go. Great. So now you have a full encapsulated cap that allows you to have good pneumo and visualization. So any questions with that? Elliot's got all the answers for you. So I know we're going to do a demonstration with this as well, so you can see how that works.
Okay. All right. So get the camera.
My screen share. Hang on just a second.
Are you guys still there?
Yes, I think they want to demonstrate something.
Is it coming up now?
We don't see you yet.
Elliot, do you want to move your camera? Oh, your screen sharing. Okay, cool.
Yeah, it did come up. Is it coming up? Or it is doing that thing again?
It looks like it's on your screen.
Is it on our screen?
Is it
No,
coming up?
it's not coming up.
No.
Does look like there may be a technical glitch that we are going to fix. But before we do that, I have to point out again that the approach really is you need to get the corpotomies done well, and there's different approaches to that. And generally we grasp the cervix quite firmly, and then we do a 360 infiltration of local anesthetic for hydrodissection, and then a sharp incision about 1 centimeter from the tip of the cervix, and then a circumferential incision as well. And then you, or generally I do a posterior entry, whether I'm doing venous or vaginal stuff, either by blunt dissection or blunt pushing away of vaginal skin, and then a sharp upward cut onto the back of the uterus once you reach the peritoneum. And from there on, you do your anterior corpotomy, and you want to identify the reflection of the reflection of the bladder. And when that has been done, that's when you then apply the gel foam platform, and through the one of the pots you create your pneumo, and we generally do about I would say between 10 and 15 centimeters water of pneumoperitoneum, and then go on to do Trendelenburg position for the hysterectomy, or whatever you're going to do, whether hysterectomy, removal of adnexa, or placement of sutures for uterosacral ligament corpopexis. And what we have found actually is that the hysterectomy part will probably take about 10 minutes. Platform placement may be 10 minutes as well, but generally with prolapse patients, it tends to be much easier. It's the suture placement for suspension that do take time. Once the sutures have been placed, depending on the number that you want, you then remove the gel foam platform and attach your sutures into the vault. People attach them at different sites. You can attach them laterally to the uterosacrals and then tie up, or attach into the vagina anterior and posterior. And then you close your vagina or close the vault. We generally pack the vagina after that has been done for removal in 4 to 6 hours. Then you perform the cystoscopy. I always do a cystoscopy. It's a habit. Then you catheterize and the patient goes to the ward. They do well in terms of pain. And like I said, the aim really is to reduce morbidity and promote early recovery. So most patients will go home within 24 hours. So that may be within 24 hours as in under the same sun, or overnight sleep and discharge in the morning, which tends to be within 24 hours. So that has been our experience with the VNOTS approach. It may be a shame that we may not be able to.
I think all we can do is if we unmute, and then people can view just
This
my
year,
computer.
we
So
can
I don't think I can just share that.
we can do that.
So if you mute yours,
I mute mine. Okay.
okay, and then if people can view.
So yeah, it is there.
We can see it. Okay.
We can see it. All right.
Great.
So
I'm gonna turn this up.
So in theater, that's what you would see, the cervix. Camera, you come and get the camera.
Yeah.
Second
Sure this is okay. It's okay.
Yeah. That's the cervix. And using your joint retractors, you hold this one, the top one.
Yeah.
Yeah. Or you still holding the camera? Holding the camera?
There.
Yeah. You advance and get your cervix. I tend to do that in the sort of anterior posterior. You see in this one that we have already done the posterior corpotomy, but generally you want to do a 360 incision. Yeah. Camera comes out. Yeah. Okay.
and you cut around the vagina or around the cervix, really. Okay. Coming up. All right. And then you open up anteriorly. Yeah, that represents the peritoneum, and we are approaching the bladder. Let's see this. Just cut, do a sharp cut. All right. Completing the division that side, and then getting the uterosacrals. I'll imagine that I have taken the uterosacrals on both sides. You then go ahead and we'll set up the geoform platform. That's it.
Want to take that?
Let's see. I see. From here, that's it from here, as in here. So after this. Yeah. No. No. Okay. We'll see what it looks like now.
And once we get the apple.
Let's see. Demonstrate the time for that. Yeah. That's not showing it. Oh,
it's just not very bright.
It's not very bright. My apologies there, guys, that our lighting is not optimal. Yeah.
We are really struggling to follow.
Can you see that view? I don't know if you're able to see that view.
No, no, we cannot. It's very dark, so visibility for us is we cannot see a thing most of the time.
And that's the view that you get inside. And you can see now that through the posterior corporetum, you can get in all the way into the abdomen. And the cervix demonstrated, and that would be your anterior portion going through that's the lip of the Alexis retractor, but that's going through the anterior portion. The peritoneum is still there, but you're your way inside. So what you then do really is you get the camera. You can get the camera. Is to go ahead and perform your hysterectomy. Pull out the camera slowly, slowly. Yeah, and then push it in. Push out a bit, pull out a bit, pull out a bit, so that I can find this. I can tell you, in a simulator, it's much more difficult compared to how you do it in real life. Just want to get that view there. Or maybe, yeah, hold it like in that view. So you hold one side, and compared to what you do when you're doing a vaginal hysterectomy, you push camera in. Yeah, in. Yeah, back a bit. Back, pull out. Yeah, that way. Yeah, that way. Yeah. You grasp your cervix and you push in and lateral, and then you get your pedicles. And in this case, the pedicles that we are going to be taking are the uterines. It's not, yeah, camera in a bit more towards this here. Yeah. That's taking your, okay, uterine has been taken. And then you proceed, yeah, keep going there, that way. Yep. Show me that portion a bit. I know from the model that the ureter is white, so that's a bit of a cheating. So there is the ureter. We're going to stay away from it. I'll keep taking my pedicle. Pull out a bit. Show me. Okay, yeah. Follow that up. Slowly follow that up. And I think I'll be able only to demonstrate the one side given the pace at which we have gone. Yeah, so search the tip of that. Yeah, go in. Right. Yeah. Right, forward, move forward. That's right, that's right. I think we are doing well. And that almost and sort of need to get that portion there. Give it time. How about it's an angle and if you take that approach? Yep. Should we keep that one? And the vessel sealing device is not as optimum. Yeah. So that gets us to the top of the, that kind of gets us to the top of the ureter, I mean of the uterus really. And to some extent completes the, yeah, we needed to get that. Yeah, hold here. Hold here. Yeah, like that. Just stay there. Hold there. Right. I'll just demonstrate. I think I'll just demonstrate. Okay, guys, just allow me to demonstrate the anatomy, and otherwise show you how things would look. And in this case, we have taken pedicles only on the left side, and I demonstrated the uterine arteries and I demonstrated the ureters. We are not going to go as far as putting in the uterosacral stitches. It's not as easy on the model, but as I have demonstrated on the videos, you can see how actually it is easy to clearly identify those structures and perform your suspension. So when the hysterectomy has been completed by dividing the other side, you then take out the geoform platform, which is this device here, and deliver the uterus through the platform. And that pretty much concludes, I think, our demonstration. But sorry about the poor lighting. Okay, thank you.
Thank you so much, Dr. Mackenzie. This is actually amazing. It's brilliant. Here we are trying to get the basics of laparoscopy, and things keep moving on so fast. And I think we won't get discouraged. We'll keep motivated because yeah, it's going to take a while for us to get there, but at least we know that there's something like this out there, and we would love to do that. So thank you for that very exciting, that fascinating presentation and the information that you have given us. We have a long way to go. And thank you so much for, just quickly, was this the second part of your presentation?
So yeah, that completes actually the last part of the presentation. Thank you.
Okay, all right, great, thank you. Thank you very much. I'm sure I'm not the only one who's confused right now and who's wondering what went where. So people, I think, are going to have a lot of questions regarding that, but fascinating. Our last speaker for this session is no stranger to us. He was introduced just earlier during our first session by Dr. Mrevanema when he spoke about transabdominal circlage insertion. He's a mentor to us young laparoscopists, and he will be talking to us again as the last speaker in this session, and his talk is about lateral parametrial endometriosis. Dr. Vuma, welcome back. May you please start sharing your screen.
Thank you very much. Let me share my screen. This one. Okay, can you see that?
Yes. Yes.
Okay. Thank you very much. I would like to present something that I've, once you start doing more and more laparoscopy, you find something that is intriguing and fascinating. And as time goes on, you actually get more insight. I should go to the slideshow. Sorry, there. Sorry. Yeah, so the outline of my talk, go through an introduction, a bit of anatomy, imaging, and then a certain classification that I found quite fascinating. I think for me, it has been actually revolutionary in the way you think about your surgical approach. And then obviously just a bit of complications, and then the take to work messages, and then some of the references that I've used for making this presentation. So basically, endometriosis is reported to be in about 10 to 15% of the women in their reproductive age. And deep infiltrating endometriosis, which is the severe form of endometriosis, in about 20% of the patients. Now, there's a subgroup of patients where it's in the lateral parametrium. So usually it's in the posterior compartment, which is where your rectum is, and then your anterior compartment will be your bladder nodules, and then the lateral parametrium, which is obviously above the ureter, along the uterine artery, all the way to the lateral pelvic wall.
Dr. Vuma,
Yes.
would you like to put your presentation into a slideshow?
That's what I'm trying
to do. Okay,
sorry.
I think you're getting there now.
I'm getting there.
Yes.
Is it in slideshow now?
Not yet.
So it will click where it says from current slide.
Okay, from current slide. Okay. Yes. Okay. Then let me go back. Yeah. Okay. So basically, by definition, lateral parametrium has always been a thing that is always very difficult. But I think if you just look at where the uterine artery comes into the cervix, the tissues around the uterine artery, all the way to the lateral parametrium, up to the pelvic wall, that will be defined as parametrium. Below the ureter, so the ureter is below the uterine artery. The ureter and below, that's the paracervix. And then below that, you will then find the paracolpium, which is when the vagina, the wall of the vagina. So basically, it's a retroperitoneal areolar tissue from the uterus to the lateral pelvic wall, and then around the uterine vessels and nerves. And then basically, this should be, for you to define this, you find it when you do surgical diagnosis. So lateral parametrium mitral endometriosis was actually reported on by Mobrook and company, and then it says that it's associated with more severe disease because in the lateral parametrium, there's also association with cervical ureter involvement, with stenosis and dilatation. And because the inferior hypogastric plexus and your pelvic spongic nerves are also involved. So you actually, most of these patients may present with voiding dysfunction. So so in your history, you need to at least whether they have any problems when they have to strain to void, or they have a sensation of incomplete emptying. And because of from the inferior hypogastric plexus, you've got your rectal branch, and then the bladder branch, and then the uterovaginal branch. So basically, if it is the rectal branch is compromised, then you find that actually have constipation because of the involvement of the rectum and the nerves. So Mabruk, in their series, I think they reported a prevalence of about 75%, but Cinatra in Italy, where it's actually a National Referral Center for Endometriosis, they actually reported figures of prevalence of 75.7%. So just to put it in perspective, what we're talking about is obviously the schematic where you have got your lateral parametrium, which is the one that is highlighted there. The dorsal parametrium is the uterosacral, going back. The ventral parametrium is what's going in front. So basically this, you can get this on 3D and 3D anatomy. You can add these templates, and then by this one I just got it from Horace Roman. So basically this is the area we're talking about, which is on the lateral side of the ureter, lateral side of the rectum, all the way to the lateral pelvic wall. And also this is also by definition the paranetrium. Also, it also goes down to the pelvic floor. So in terms of diagnosing lateral parametrium endometriosis, the best imaging is MRI scan. But now the major problem we all have is it is user dependent. So most of the radiologists are not aware or don't even understand what they are looking at. And if you want to look at the pelvic nerves, for example, your sciatic nerve and pudendal nerve, or even inferior hypogastric plexus involvement, you should basically request a targeted MRI neurography. It has been reported that the MRI has a sensitivity of 8.3% for diagnosing parametrial endometriosis and a specificity of 98.6%. But the problem with all that is that it depends on your radiologist, your radiological services. So lateral parametrial endometriosis is reported with co-localization in other organs, like bowel involvement in 87%, bladder involvement in 21%, and ureter in 21%, and then also involvement of the vagina. I found Horace Roman in his where he's working now in Bordeaux, where this is the website for their unit, and he elegantly described parametrial endometriosis into two types. The most common type, the type 1, which occurs in 85%, is the one that I think we commonly encounter, where it infiltrates the rectum, the vagina, and then so these are the most common nodules that we come through. And then the other one, which is a bit more lateral, is the which is around in 10-15%, which is actually much rarer. But in this case, usually it's rare to get rectal or vaginal involvement, although you may get bladder involvement as well. So basically that's the type 1 nodule to be on the lateral aspect. And then MRI scan, I mean, I'm so poor at interpreting MRI scan, I have no clue. I just have to go with what they tell me. And then this is the type 2 nodule, schematic drawing. And then on MRI scan, this is what it would look like. It's actually much more lateral from the midline. So in terms of your surgical approach to tackling parametrial endometriosis, because one of the issues that is there is that most of the patients will always have repeat surgery. Is it because of recurrence or is it incomplete surgery? So invariably, one of the biggest challenges that I've found is that we always approach these patients with incomplete information. The radiologists always never, give us enough information. Clinically, we may not reach that far when you do. You may get an impression when you do a rectovaginal examination to say whether there is actually infiltration. So you will be able to prepare this patient appropriately with the bowel preparation and the low residue diet for about 5 days as my protocol. So normally the type 1 nodule, you should approach it medially, which is from the posterior from the posterior broad ligament, profusely from the broad ligament. And then for the type 1 nodule, type 2, sorry, you actually go between the psoas muscle and the internal iliac artery and vein, and you go approach it that way. But in terms of approach, you can actually mix and match because of the extent of the nodule, because it can be a type 1 nodule, but it may also maybe extend far more laterally. This is the basis of my talk. Basically, these are the steps that Professor Horace Roman actually advocated, so that you actually stay out of trouble. And deliberately, when I approach these patients, I always release the open, cut the only white line of Tolts, mobilize the sigmoid rectum, and then open that space that way. And then I do uterolysis. I always start on the left side, and then also then if there's bowel thing on the other side, then I also go there. So uterolysis. So if it's one side, then you actually then can just come from that side. But in this type of nodule, usually you find that the rectum is attached to the retrocervical area, rarely to the vagina. So there's usually space between the cervix and the vagina. The rectovaginal nodules are actually quite rare. You actually get a retrocervical attachment. So you need to open that space and open the real pouch of Douglas, and then you look for the retrovaginal septum to think. So basically, the whole sequence is just you do your uterolysis. You actually then free. If you have to suspend the ovaries, you suspend the ovaries. If you have to suspend the uterus, you either use, if you have a uterine manipulator, a manipulator, you can use that. But I also usually put a suture through the anterior abdominal, through the uterus, and suspend the uterus to the anterior abdominal wall. Then after the uterolysis, then you open the pararectal space. And what I've actually noticed that makes a big difference is try to hug the rectum and dissect going that way. That way you avoid perforating the rectum, and actually because most of the time the fat, the pararectal fat is usually actually very hard, very dense. But if you keep close to the rectum, you will actually then get as far down as the levator ani muscle. And then you then dissect, prolong towards the rectovaginal space. And then if you can, I mean, most of the time the inferior hypogastric plexus is actually involved, so you may not see it. So then you come back to the sacral promontory, and then you can actually then open it. He recommends that you open transversely around, just leave the peritoneum over the sacral promontory, open it transversely, and identify your superior hypogastric plexus at that level. And then by pulling, you should be able to see both, because if you pull the one visible hypogastric nerve on one side, you actually be able to see the direction of the other one, because they all get connected at the superior hypogastric plexus. So then you incise the peritoneum, and then you then see where your common iliac is, then external iliac, internal iliac, and also below that level, then you find that there is the so your internal iliac. You start from the top, and then you go down, dissect it, and then after that, below the level of the, well, things are, for me, it looks like they're all stacked. So your first layer is the peritoneum. Then you get the arterial vascular supply. Below the arterial vascular supply, there's usually the venous system, which is the troublesome, the internal iliac veins. There are various, in terms of variations. The veins normally are usually inconstant. The arterial system is more constant. The veins are usually inconstant. And one of the biggest problems is obviously unintended venous bleeding, which usually, because of the thin wall of the vein, they're always difficult to obliterate using bipolar. You are more likely to succeed with an artery rather than with a vein. So you then integrate, then go down and open the Okabayapi space, which has been elegantly described previously. And then you always try to go middle end. I use hemoclips or endoclips to basically those small veins as they feed into the internal iliac vein system. It's always prophylactically to actually either you should dissect in case they start bleeding, then you should be able to clip them. But most of the time, the veins, as they drain from the nodule, you should actually be able to prophylactically clip them and then cut them. And then you keep on dissecting below the veins. Usually there is a peritoneal, the parietal peritoneum covering, separate that from the nerves. The nerves are below that parietal peritoneum. So if you open that, you'll be able to see the nerves, which are a bit deeper. And below the nerves will be obviously your vessels, your muscles, and eventually the bone. So you always dissect along behind the venous thing to eventually you get to the piriformis muscle. So where the sacral roots S2, S3, S4 usually lie on top of the piriformis. So if you start more at the top of the close to the infundibulum, to the sacral promontory, as you get into the pelvis, you will be able to see the lumbosacral trunk, and then S1, S2, and then most of the time, according to Professor Roman's studies, most of the nerves that is actually involved with part by type 1 and lateral parametrial nodule is usually S3. So usually S2, S3. So then after that, then you then go in, and then if the nerves are involved, you have to go deeper, and then you just try to dissect the sacral roots, and then you obviously identify the sacral nerve and pudendal nerve if there's a need for that. But it just, what will guide you is obviously how far the nodule goes. So you try to just do the perineurium rather than to cut the nerve, but you try to remove as much of the nodule as you can. And then if you are lucky, sometimes the inferior hypoglossal plexus is actually involved in this nodule, so you may not be able to spare it. And then, so if you have bilateral involvement of parametrial nodules, you actually maybe tackle the one where there's more severe disease. And there's also an option of saying, do you remove the disease, the so-called nerve sparing? Do you receive, so on one side, you try to remove as much as possible, and on the other side, you might probably leave the nodule there. Now, in terms of nerve sparing, difficulties in endometriosis surgery is always almost, in most cases, very impossible, because the nerves have actually been trapped and involved in the inflammation around the nodule. So it's always very difficult to spare them. And let me go through the, so basically those are the 10 steps that he says, but you can move from one to the other. They're useful, but not mandatory. And you should actually be, for each patient, you should individualize them. And one of the things that is there is that if there's like on the normal side where you should be able to actually dissect the pelvic splanchnic nerves. And but if this is included in the nodule, we just basically take them. So one of the big things is that we should actually elicit in your history whether this patient has bladder or rectal dysfunction before the surgery. because most of the time they'll blame the surgery. Meanwhile, this problem was there even before the surgery because the nerves were already involved because of the lateral parameter endometriosis. So postoperatively, this is the Professor Roman series that he published recently in Journal of Minimally Invasive Surgery, JMIG. And then one of the biggest thing that is there is that there's 14.2% of rectovaginal fistula, 2.8% of vesicovaginal fistula in retrovaginal fistulas, and some patients had to self-catheterize. So this is one of the things that if you had complete information, you will actually be able to cancel the patients on the possible complications when you do lateral paraperimetral resection. You use these statistics, and then normally you always work with a colorectal surgeon who is interested, because one of the biggest problems that I find is that most of the guys are not interested in the effort that this disease process. So basically that is just the schematic about where basically your nerves are. It's rare to get endometriosis involved with the obturator nerve, but it has been described. But usually your S2, S3 will basically be your sciatic nerve and pudendal nerve. And your pelvic splanchnic nerves, they actually, just as the nerve root exits the sacral foramen, that's where your the pelvic splanchnic nerves actually travel to the inferior hypogastric plexus. So, I couldn't edit some of these videos, but these are some of the patients. This patient, I think, I'll just play it fast. She presented basically with chronic pelvic pain, and then it was chronic pelvic pain, infertility, dyspareunia. She had a bit of constipation. So clinically, I suspected that she had endometriosis, and I did a vaginal rectal examination, and definitely I could feel there was a nodule in the left parametrium on the left side and also the vagina. But unfortunately, surprise, surprise, the MRI scan, which was worth 15,000, said everything was normal. So I just wanted to show you when we went in, although I didn't believe it. So, no, okay. This is not, I think I'd already, no, I'll go and start. But anyway, I'd already started here. I couldn't find the earlier one, but I'd already started. So basically, this was the, on the left side, that was uterolysis. I'd actually put a vascular tag on the ureter so that I could actually see, and that is the rectum. And then one of the biggest problems also you need to prepare for if you do endometriosis surgery, usually a bloody surgery. So you need, obviously, I normally use a bipolar and a harmonic. So that's the other side, which was also involved. So your retrocervical endometriosis actually moves almost like a butterfly from both the left side all the way to the other side. So after this, I did a uterolysis on the right side. I think I am going to show you, yeah, there. So basically this was obviously removing opening the peritoneum and removing that diseased peritoneum to actually visualize the ureter. And then basically just dissection. And then I think if you're lucky, we should be able to see the ureter vermiculating. I like that term. They say the ureter vermiculates, it doesn't peristalse. So thank you, Dr. Mackenzie, for that. So then quickly, so basically then I was just taking that down, and then I'll stop this one and then go to the other one. So basically then I also then mobilize, so the pararectal dissection, then I mobilize normally from the right side, left side, and then you join the two. So I go rectum and mobilize the rectum all the way to the bottom before I actually mobilize it from the back of the cervix. Let me see how far this goes. Okay, this is, I think, it was almost done there. Yeah, so let me go to the next one. Maybe that's better. Okay, this one. Okay, so I'm trying to go. Yeah. So this was supposed to be the first video so basically this is what it looked like when we started, where obviously the bowel was adherent, the tubes were adherent, but eventually when we finished, we could find that we did a dye test and the tubes were open, and then so basically these I just borrowed from Professor Posova, who does neurophysiology from Zurich, where he says pelvic endometriosis is like a praying mantis, because he says if left too long, it will involve everything. But actually, because of its simplicity, it always looks like it's going nowhere. So the sooner you operate on these patients, the better. So my take to work message would be obviously a detailed knowledge of anatomy is a must. And every time you operate, I think it's always better to have a standardized approach and you actually move step by step. And then the more you operate, the more you gain insight. And then one of the insights I actually got was most of the time is we're always scared of bleeding from the veins, internal iliac vein system. So, but basically, if you dissect that out prophylactically, you start from the top and down, so that if ever there's any bleeding, you should actually be able to put in a hemoclip or a endoclip. And then also you need to share your experiences and what we call collaborative learning. And I also would advocate for this multidisciplinary team. But for me, I think it's just not like in this case, the way the case ended. We found that she actually had a nodule which had not been diagnosed. We had to resect about 15 centimeters of bowel, and the proximal part of the bowel, although despite the bowel preparation and 5 days of low residue diet, you could find hard stool that could not have gone through the stenosis. So the surgeon, because there was fecal material in the proximal segment, decided to do primarily sigmoid colostomy. And then we left a drain in, but then he actually converted to a laparotomy. So the point that I'm trying to make is that normally because I didn't know that we're going to end up this way, the general surgeon who actually does more laparoscopic work was not available. So we had to go with the other general surgeon who says he was not comfortable. Although I dissected and mobilized the rectum and the nodule and everything, all it needed was obviously to use a linear stapler and maybe a circular stapler to re-anastomose. It was not comfortable. And I think through this wonderful society, I hope one day we will have centers of surgical excellence in Zimbabwe, and I pray that people should be able to do laparoscopic surgery for ectopic pregnancy at a district level. That's my dream for Zimbabwe. Thank you. So those are my references.
Thank you so much, Dr. Vuma, for such a brilliant presentation and on such a complex procedure. We are constantly complaining, for example, during the winners, that the anatomy is a bit daunting, and you're making us realize that it's important to actually go through and understand the anatomy, because it's obviously everything when you're dissecting for endometriosis. So we've had our three presenters from Dr. Nyakura, Dr. Mzamiri, Dr. Mackenzie, and Dr. Vuma was our last presenter for this session. And I will just start with the question in the chat box. This is for you, Dr. Vuma. Chipo Gwanzura says, thank you for the presentation, but she could not clearly see whether you use the medial, which is the endometriosis, or the lateral, the oncologic approach, when you entered the pararectal space.
No, I use the medial.
Okay.
In this case, I use the medial, yeah. But I think one of the challenges there, I think I had a challenge because initially, I think everything was evolving as I was going because I actually pre-operatively, I had no knowledge of the extent of this nodule. So it actually went on as far as I could, and I could manage to get it through the medial approach, but I think I could have actually then, if there was a problem, I would have maybe gone the oncological approach, go through the ilo-lumbar approach, and then tackle it from that side to completely remove it. But one of the things also that she had no neurological symptoms to say for example, she sciatica or pudendal neuralgia. So I didn't think there was any need to go that deep to dissect the nerves.
Okay. Thank you, Dr. Gonzalo. I hope you answered. Dr. Mackenzie, when you entered the peritoneum, I assume that this is a blind procedure. What do you use when you enter? Where you talked about you do an anterior colpotomy. What are you using to do this?
So to start off with, do hydrodissection, but as an aid before you do your hydrodissection or your sharp dissection, you want to grasp the cervix, apply traction, and try to feel where the uterosacrals are posteriorly before you do all those things, so that you actually have a marker to see where the uterosacrals are attached to the cervix, and then aim for that point when you do your incision. So that's the approach that I do with either going for vaginal hysterectomy alone or doing V-knots. So it's traction, hydrodissection, sharp dissection, and then blunt cephalad pushing or dissection of the vaginal skin. And then, you know, the cul-de-sac just becomes obvious. You then grasp it with either an Alice clamp or a bonis, and then cut above the Alice clamp or bonis while applying traction posteriorly, and you cut up into the back of the uterus, and the cul-de-sac just opens. If you're doing V-knots, of course, the challenge is to do an anterior colpotomy as well. But if you're just proceeding with the vaginal hysterectomy, you don't need to do an anterior colpotomy. Just do an extrafascial hysterectomy. Just continue taking your pedicles, and the bladder anteriorly will fall away as you go up.
No, interesting. Yes, it does. It does. And I think it would be much better when we actually see what we're doing. Because yes, for me, and I think for some other people, it does sound complicated. It does sound quite complicated, because I was trying to imagine, where are you actually putting the ports?
So, okay, the ports, as in the ports, can I quickly, I'll quickly grab the thing again. So you have witnessed a vaginal hysterectomy or done a vaginal hysterectomy, right? So we've said you make your 360 incision, you enter posteriorly and anteriorly, you take your first pedicles, being the uterosacral pedicles, and then you place your Alexis wound retractor into the anterior colpotomy and posterior colpotomy, such that this white portion is then on the vagina, right? So you now have this space where you can put instruments or even put your hand or a pack, and the ports for operation are this thing. So your wound retractor is your single entry point, right? And the gel foam thing, is what allows you to then put your ports, because you come in, this is your trocar. onto the thing that on the cap that goes onto the Alexis wound retractor, and that's your first port. And in most cases, the ports for the 2 ports are just for the surgeon. The actual incisions or dissection doesn't require an assistant. Your assistant is only devoted to the camera. So that's the camera port. So you can see how one hole or one port becomes 3 ports by the gel seal port. If you wanted an assistant really for the operation, yes, you can put an extra port onto the gel seal cap. So when you then put in your instruments, they're going through the wound retractor and into the cavity. Or even if you want to put your hands, it just goes in like that.
Great, thank you. Thank you for that answer.
You're welcome.
I had invited questions, but I don't see any questions in the chat box. Anyone with questions, this is the time. I think you can raise your hand and we can ask. This was such an insightful, such a brilliant session. If we have any questions from our participants. Okay, I've got here from, again, Dr. Gwanzura, and she asks, what's the purpose of the pneumoperitoneum for V nodes, that is? Does the abdomen become tense?
Okay, so guys, V nodes is laparoscopic surgery that still requires pneumoperitoneum, only that you are not making incisions or you're not putting ports on the abdomen. And you are going to be looking from bottom up versus looking top down. So you still need pneumoperitoneum. And the distension on the abdomen is the same as the distension that you get when you're doing your standard laparoscopic surgery. If there's going to be any excess really on the abdomen, it comes out when the gel form does that. But the pneumoperitoneum is only, 12 millimeters mercury, and with a good Trendelenburg bag, especially with a patient on a non-slip mat or a bin bag, you have more than adequate space to do your surgery. And if you wanted, you can call it vaginal assisted laparoscopic surgery as opposed to laparoscopic assisted vaginal surgery.
Perfect. I hope, Dr. Gwanzura, you have been answered. And any other questions? I don't see any hands at the moment. So some of us winners are still right at the beginning of trying to get to laparoscopy, though in Zimbabwe, we do have our experienced laparoscopists, but yeah, this is quite a challenge. Dr. Vuma, you talked about, yes, please go ahead.
It's Dr. Ziki.
Ziki, yes.
I just wanted to make one comment. Our focus or our desire to actually do V-nodes comes from the fact that vaginal surgery is actually complicated, and laparoscopic surgery from the abdomen is actually very complicated. Once you get past the part of doing colpotomies, laparoscopy from the vagina is actually very simple or very easy. So yes, I agree. If you're doing yours from the abdomen, you're actually making your life much easier when you transition to doing V-nodes. like I said, or as you saw from the videos, that when it comes to actually doing the surgery, or as in taking the uterus out, it's straight cutting, and on average it's 10 minutes, right, to get your uterus out, as long as we're talking normal size uterus. And the anatomy is much easier, and the orientation is more straightforward compared to when you're doing your say TLH, for example. So I would say look at it with positive anticipation that when you transition or when you start doing V-nodes, life is going to be much easier.
Great. Wonderful. Then I had missed a question. Dr. Vuma, what's the level of exposure needed before one can confidently start doing these cases, endometriosis cases, that is?
And I think endometriosis is the most difficult surgery because the tissues are hard. The anatomy is distorted. Unlike oncology, I think the tissues are much softer. So I think you need to operate regularly, because I think we like what you are saying, you are learning anatomy, but every time you learn new things with each case. So the more you do, the more you actually get, as I was saying, more insight. So for me, it's once you start, you keep learning every day until you are confident, because the question is, if you understand anatomy, one of the biggest problems why people convert is they say, oh no, I may be bleeding. But if you understand where the bleeding is coming from, and then you take measures to actually prophylactically stop the bleeding, then it will be actually much easier. And then the other thing that I also find, that because laparoscopy gives you the best vision, I always find people say, no, I prefer to convert. But then I ask myself, so what are you doing better blindly? You have confidence, a bigger incision, but surgically the adhesions, the stenosis, everything is still the same. So what are you doing better, which you can do laparoscopically? I think, I don't know if there are any comments. Yeah.
Definitely. Dr. Mzamiri, please go ahead.
Yeah, it's just a comment to speak to that. Yeah, I do agree with you. Laparoscopic surgery is challenging, and more so with patients with severe endometriosis. As to the time it takes, we run a fellowship program here in Waikato, and that takes a couple of years for a fellow to go from a point where they come in relatively skilled in laparoscopic surgery, but to get to the point where they're comfortable with severe endometriosis and doing the level of work that we're sort of talking about. It takes them roughly, by the time they get to the 18 months, they are becoming a bit more comfortable in the pelvis. And by the time they come to the last 3 months of training, we expect our fellows to be comfortable in doing advanced work. So it does take a bit of time, but we're talking about our program. Our fellow is exposed to laparoscopy 2 lists a week, clinics every week. So they are immersed in endometriosis work from the get-go. So that's the kind of time span that we're looking at, and that we do and we utilize in terms of getting to that level.
So yeah, so I was saying you definitely need to be exposed to this kind of thing, and I think we are beginning we're getting there by this course. Then Dr. Shava. Dr. Shava, I see your hand up. Dr. Marere?
Sorry, my hand is not up.
Oh, okay. Yes, Dr. Shava, please go ahead.
Yes, mine is more of a comment to Dr. Mark. Now that we have introduced eyes to vaginal hysterectomy, would you think the fear of doing vaginal hysterectomy is going to go away in the sense that this should actually translate in these young surgeons actually liking to do vaginal hysterectomy more often than they are doing the total abdominal hysterectomy right now. Dr. Mark, your comment.
Yeah, thank you for the interesting question. I think it should go away. Number one, V-notes is exciting, and young people are always looking for exciting things. But really, like any surgeon, you need good mentors to go through the basics of vaginal surgery. And it's only, I would probably say it's only when you master the basics or the necessary steps for vaginal surgery would you then progress to doing V-notes. And once you get that, V-notes is very, I would probably say, very easy. In terms of fear, I don't know, it probably depends on maybe the facility that you work in and the surgeons that you probably work in as a trainee, because I probably have not come across many people who are afraid of vaginal surgery, except when it comes to using the capio for high uterosacral ligament suspension, because you can't see. But vaginal hysterectomy alone, or vaginal hysterectomy per se, tends to be a bit more straightforward as it is indicated. Even if you wanted to do open pedicles with your ligation impact or NSIL vessel sealing device, you actually find that taking pedicles tends to follow a straightforward path, as long as you have respected the uterosacrals and likewise respected your ureters. So yes, it's something that we keep working on to get more people excited, to get more people converted, like Dr. Mzami, to vaginal surgery. I think the future looks bright.
I guess you're trying to get a comment from me, Dr. Mackenzie.
No way, you can comment if you
Well, thank you. I think our time is now 12:58. We had hoped to, okay, we are 3 minutes, running 3 minutes behind time. So I will ask, thank you so much to our speakers for this session. This has been a brilliant session, an eye-opening session. And thank you for the engagement. Now, our next sponsor is from Devere. I think we're going to give them about 10 minutes to talk to us before we go for our lunch break. And Dr. Mackenzie, I heard that it's after midnight. So thank you so much for being with us.
Yeah, you're welcome, guys. I'm enjoying the presentations.
Right. So Devere, you can please put your show on, your slideshow on.
Afternoon, everybody. My name is Shannon Apple, and I'm with my colleague who is Cherise Nydam, and we are consultants with the Devere Group. Sorry, I just want to share my screen. Okay. Okay, so for some reason the slideshow is not going on. Okay, so we as Devere, we've established in 2002. Our CEO, Nigel Green, he is British, and we provide international advice to expats and international clients. So us as Devere, we provide independent financial advice to expatriates and international investors who are based in Zimbabwe. So whether you're planning for a safe and secure retirement or whether you'd like to do a secure saving for your children, we offer bespoke financial solutions which will help you guys achieve these financial goals over the medium to long term.
Over long term for the child range is probably the most important part of education. Just know that university or further education is probably the most expensive part of for any child. So putting a savings in place for that purpose, of course, does help over the long term.
Sorry, we cannot hear you very clearly right now.
Oh, can you hear? Is it clear?
Hello?
Hi, you're back. Please try speaking again. Yeah.
Sorry. Okay.
We offer a range of products and services to help any investor for any particular reason that they might want to have. As mentioned, we have regular savings plans. We do international bank accounts. We have lump sum products, primarily for if you've got money that's just in a bank account and not earning you interest. We do property, so probably UK property is the most popular, as well as property in Germany and Portugal, and citizenship programs. So there are some countries who offer citizenship through investment, either through buying a house or giving a government a donation, obviously in exchange for residency and citizenship. Hello, can you hear us now? We've just had a message again to say that you can't hear. Can you hear us?
Now we can hear you, but we are struggling in between. So there's a tendency, yeah.
Okay, all right, well, we'll continue, and if you just let us know when you can't.
Okay, so in terms of our regular savings, they can be set up for multiple reasons. Okay, so obviously just a basic saving if you have no kids, but obviously somebody always wants to save towards their retirement or has some reason for doing so. We have minimum terms on these investments, which would be 5 years. The maximum term is the sky's the limit as to what you want, but we don't usually recommend that you save for a term that's not achievable. So we sometimes recommend 15 years maximum. Our minimum saving will vary per product as we have multiple investment houses that we use. But on general, our 10-year minimum amount is $300 per month. On a 5-year term, our minimum would be $600 a month. And you do get flexibility in the way that you would contribute. So you could do monthly, quarterly, half yearly, or annually. This decision is entirely up to you, and it can always be changed on the anniversary date. We do all our investments in tax-free havens, such as Mauritius and the Channel Islands. Now, benefit of a regular saving would be that you don't really need to time the markets. So regardless of when you go in, you will still benefit. There's something called dollar cost averaging. Every month that you buy in, you will buy at a different level, which then over the medium to long term would give you the growth that you need. So we can compound interest as we go over the medium to long term. So it doesn't work like a bank account. It's also important to understand that for these things to work, you need to contribute towards them regularly. The more money that you put in, the better the growth becomes over time. We do have access to them as you go along, obviously, because if you have an emergency, you should be able to access. But for them to do very well, you'd want to contribute into them over a specific period of time. In terms of our lump sum products, so our lump sum is known as a portfolio bond. So the portfolio bond basically works as a tax wrapper. It protects you against inheritance tax and all that kind of stuff. So should your money be in a bank account and something happens to you, then that gets tied up with your estate. With a portfolio bond, it works a little bit differently. So if they're tying up your estate and all that, they cannot touch the portfolio bond. The reason why the main way we invest this money is with something called a structured note. Now, a structured note is basically designed to protect your capital throughout the life of this note. It also provides you a fixed interest over a certain period. Now, it pays something called a cash coupon, and that's there's different rates in which we can pay. So they range between 8 and 24% per annum. Okay, but what happens is every single quarter, it will pay you a cash coupon, which goes into a cash account, and you can reinvest this money or you can access it. It's entirely up to you. A portfolio bond also provides you with 85% access to the cash upfront, and our minimum start from £40,000 or $60,000 US. Now, the reason why we also set these in place is because you don't want to sit with a lump sum of money in a bank account. Obviously, all that happens is that inflation eats that money away. If you think of what $100,000 could do for you 5 years ago versus what it can do today, obviously these things are inflation adjusted and they grow your money accordingly. With the comfort of knowing that your capital remains safe. So even if markets are fluctuating, your money remains safe and it still pays you a coupon throughout.
Property, UK property, going back to what I touched on earlier, is probably the most lucrative in the world in terms of both capital appreciation and rental yield. The UK has a demand of around 300,000 new builds per year. And at the moment, output is about 266,000. So this means that demand is always outweighing supply. We have access through our partners, our developers based in the UK.
One more minute.
Okay, to properties throughout the UK. We also have mortgage facilities available to our Zimbabwean clients of up to 65% of property value. So, you know, looking at your equity that would be required to go in is much less and often more beneficial than buying property locally here in Zimbabwe. So this just gives you a bit of an outline on what we do. Obviously, this is all dependent on each individual. So what we generally do is have a one-to-one meeting with you and look at your particular background and base our recommendations on you and what your particular need might be. So I hope that was all clear enough. And yeah, thank you for listening to us, and we hope to hear from you soon.
Thank you. Thank you very much. Thank you for your presentation. Last presenter for this session is again one of our sponsors, DRMS. May you kindly start sharing your presentation, and I will give you about 7 minutes for this presentation.
Right. Yeah, my name is Simbarashe Ncube from DRMS Africa. DRMS Africa is a private, locally registered entity. Our line of business is the development and provision of medical practice management systems. We currently have a system called Doctors' Rooms Management, Doctors' Rooms Billing and Management System. This is designed to manage the operations of medical practices by providing functionalities which include patient records management, appointment management, billing management, and data management. So with our time in the medical industry, we identified certain problems that the medical practitioners have been facing in running their practices. So these problems include the following: multi-currency issues, claim form rejections due to data capture errors, poor data management, both cash and patient both cash patients and medical aid patients, centralization of data, delayed medical aid payments, lack of tailor-made medical systems for the Zimbabwean market, a lack of data migration support when you want to move from one system to another, and also poor expenditure management. Can you go to the next slide? So I'll go straight into what our system delivers in terms of solving those problems. So there's an issue of a rate system. This feature is designed to capture the rate of the day, thereby allowing the users to capture and record all transactions in the manner they okay. This will eliminate any transactional recording challenges that we are currently facing in the market. Next slide. Patient management. For all medical aid patients, the system will directly access the information from the medical aid database, thereby eliminating any human errors that will lead to any claim form rejections. And there's an ability to upload documents to each patient account. Next slide. Diary management module. The system is a diary management section which deals with capturing of all patient daily appointments, which the doctor has full access to using his or her own login credentials. So next slide. Medical aid patient lookup. Before creating a new transaction, that is a claim form, the system allows users to check the validity of the patient medical aid before rendering any treatment. Of late, we have realized that as medical practitioners, you might tend to treat someone who has no benefits or who has actually lapsed benefits from the medical aid. So we have managed to come up with this system so that we can avoid all that loss of income. Next slide. Billing management. The system gives you the ability to capture new transactions, that is claim forms, that is the AFOS and CMAS claim forms. These are preloaded in the system with the doctor's credentials. And we have also added a feature where the doctor has the ability to capture all the work done. Of late, we have realized doctors, when you are sending your claim forms, at times there are certain tariff codes that are omitted from the claim form by your administrators. So the system will give you an allowance as a doctor to actually capture all work done, thereby eliminating any shortchanging when claiming from the medical aid. Next slide. Data's management. This is a function we designed to help all users to capture all their data's pre and post system installation. Due to poor data's management, we realized you are losing income because of unpaid debts or overdue debts. More oftentimes, we've realized that you still have data stretching back as far as 2018, 2017, and as a medical practitioner, you can't even track that, but only the ladies at the reception will know who owes us money. So this is a system now where as the doctor, you can actually log in and actually have a track and see whether these data are being followed up and are we actually receiving our money from debtors. Next slide. Reconciliation. Medical aid reconciliation will only be done once we receive remittance advices from the medical aid, thereby giving you a true reflection of the practice performances. Next slide. Expense management. The system allows you to capture all expenses as they occur. This function is also available on the doctor's user platform, thereby allowing the doctor to capture any expenses remotely. So with this function now, since the system is now remotely web-based, as a doctor, you can actually capture and record expenses as you are actually incurring them on the go, because you can actually access your system over the phone, tablet, laptop, desktop, wherever you are, you can actually access the system. Next slide. Creditors management. The system tracks all unpaid expenses, that is creditors, that is making it easy to manage all payments that needs to be done at the surgery. So with this platform now, you are able to actually prioritize all your payments that you need to do to all your creditors, thereby helping you to actually track all payments that needs to be done. Next slide. So The system generates the following reports. So I have just mentioned a few. There is a whole list of reports that the system can generate for you on the go while you're using the system. So we have an income report, expenditure report, payments report, data's report, and a whole lot of other reports that the system generate. The system will handle the doctor's entire practice operations, and all other returns will be done manually. That is in relation to ZIMRA, NASA, and NEC. Next slide. So the system is a dashboard. The dashboard has the following shortcuts. These shortcuts will give you an overview of the practice performance on a daily basis. That is the number of patients that you have actually treated, shortfalls received for the day, the open claims that you are working on for the day, patient data, and all day appointments, making it easy to access vital data on the go. So this will give us a better workflow and a better understanding of how we are performing on a day-to-day basis.
DRMS, I'll give you 1 more minute.
Okay, thank you. So the major benefits of using the system, we have 24/7 support system, regular updates to make the system more efficient, ability to customize the system to meet individual needs, a higher level of data security, and also as DRMS, we have a greater understanding of the medical field. In the last slide. So as DRMS Africa, we are coming up with an offer to all the clients, to all the doctors that have attended the conference. And our offer is a $20 setup and training fee, and a 20 days free trial run for all doctors in attendance. Then the cost of the system, the monthly subscription, is actually $75. And this $75, it's for 3 users. That is the doctor, the receptionist, and the administrator or the accountant. So for all doctors who are interested in the system, we can actually sign you up for a free trial run for 20 days, while you can actually see how our system works and the functionality and the benefits that we are bringing in as DRMS Africa. And what you only need to pay, it's a $20 signing up fee for your training and setup. So thank you very much for giving us this opportunity to present our product. So all those who are interested, we can actually make a follow-up. We can actually get the referrals from Dr. Zeki or any of the administrators. Thank you very much. Any questions?
Yes, I've got something in the chat box, and they're asking what does a DRMS claim form format to medical aids incorporate ICD-10 codes?
Yes, in the system, what we have ICD-10 codes preloaded in the system. We have tariff codes preloaded in the system. So when you are doing our billing, we will actually have the ability to search by the code or type in the description of the ICD-10 code that you are looking for.
Then the last question, what difference does this system offer to 263 Health, which is directly linked to the medical aids?
Now, the difference between DRMS Africa system and 263, it's a switch that only connects you to the medical aids to allow you to send claim forms. But DRMS, it's a system that manages the whole practice, delivering from data's, reports, income, expenditures. So we have a system that deals not only with sending claim forms, but with the day-to-day running of the day-to-day administration and running of the practice.
Thank you very much for your presentation. And I think this brings us to the end of this session. We'd like to thank our international presenters and our local presenters for such awesome presentations. And I will mention Dr. Mzamiri in absentia. I think he has left. He's again in a different time zone. But thank you to all our presenters. You have been brilliant. We will meet again at 2. Now we are on a lunch break, and we will be back at 2 where Dr. Gwanzura will be chairing the last session of the day. Thank you all for being here.
Sorry, maybe you didn't see my hand raised.
No, I didn't.
Sorry.
Okay. I'm just kindly asking the last presenter to maybe send me a portfolio or maybe what they provide in terms of services and the charges and everything. Is it possible for them to email me? I'll send in my email on the chat.
Okay, thank you very much. We will kindly do that once we receive your email.
Okay. All right. Thank you.
Thank you.
Sorry about that. Thank you very much, everyone. We'll see you a little later.
So good afternoon, ladies and gentlemen. I hope you can hear me. Welcome to the third session of our CME Day, our Zimbabwe Society of Gynaecological Endoscopy Annual Conference. We've had an exciting lineup of speakers in the morning, and we're going to continue to do so. All right. Thank you, Dr. Mhlanga, for sharing your first slide. So just a reminder of the ground rules. Remember to keep your mics muted. Secondly, Dr. Nyakanda is expecting your nominations for selection of the committee of the ZSGE later on during the AGM. And I would just like to give special thanks to our speakers this morning, particularly the speakers from New Zealand who were online at midnight in their time, and our speakers from South Africa and our local speakers. And a special thanks to the chairs. This morning I'll be chairing the session. By way of introduction, our first speaker is Dr. F.G. Mhlanga. He's an obstetrician gynecologist with a keen interest in minimal access surgery. He's a senior lecturer at the University of Zimbabwe. He's also involved extensively in clinical research and is the site leader for Spillhouse CRS. Dr. Mhlanga, you can go ahead with your presentation entitled Outcome of Pregnancies Following Laparoscopic Myomectomies.
Thank you, Madam Chair, and good afternoon, friends. Good evening or morning, depending on where you are.
It could be from my end, but Dr. Mhlanga, I can't hear you. Can anyone hear him?
Can you hear me?
Yes, we can hear you.
We can hear you, Dr. Mhlanga.
Oh, now Madam Chair can't. So I guess I should press on. Would that be okay?
Yes, I suppose so.
Okay, so it is an honor and a privilege to be leading the discussion on the outcome of pregnancies following laparoscopic myomectomy. My talk would focus on what the issues in laparoscopic myomectomies are and how they affect outcomes. The how in terms of my local data is work in progress, so you bear with me, but I'll share my thoughts all the same. So as we know, by choice, women are beginning to deliver late in adulthood. Some will be pursuing academic careers and you know, different objectives. This makes it possible that they would have fibroids because they're common in this late adulthood. It is possible that they may have sought help and they would have had a myomectomy. The current thinking is myomectomy is probably best done laparoscopically if it's possible, for the reasons that I'm outlining: less pain, faster return to work, and less likelihood of post-operative adhesion formation. The challenge that we have, though, is there are some issues that relate to the laparoscopic myomectomy that may not be, you know, pleasurable. One of the biggest challenges that is being faced is, isn't laparoscopic myomectomy a hazard in terms of possibility of uterine rupture? So if you go back in the history, prior to the 2000, there were a couple of case reports when laparoscopy started being implemented in different places of ruptures, mostly small scale case series. The thinking is maybe if you compare laparoscopy and open surgery, the suturing in open surgery is more likely to be secure. The use of energy sources is more likely to be directed and measured in open surgery than in laparoscopy. So it is possible that when we use energy sources that we discussed in the morning, we can go to, sorry, this is moving on its own, but anyway, it's you can get myolysis and necrosis. So this leads to the question that how did people decide to follow up women and say, is this real? So Dubuisson is one of the pioneers, one of the first people to create a large cohort. That's why I picked on his study where he looked at all these women that they followed up in France, had laparoscopic myomectomy, and became pregnant between 1989 and 96. They sent them a questionnaire and asked questions related to their pregnancy outcomes. So they actually noted 3 ruptures. And of note is they were young women, nulliparous in 78%. I mean, 78 of them, they were 100. So that's equivalent to a percentage. Most of them had one fibroid, and it was mostly intramural. When you look at a population level, there was some Korean data, very huge numbers between 2014 and 2015. 38,000 women with diagnosed myoma, some with a history of myomectomy, and almost 750,000 women without myomas. So this gives you a good base to say of these pregnancy outcomes by the different strata, how many actually ended up in with rupture. So the overall incidence in this cohort was 0.71%, and this was typically more common in women within 1 year after a myomectomy. And of note is it was significantly higher in women with a previous myomectomy. If you look at the adjusted odds ratio, 12 times, that's a very high magnitude, and up to 25 if you're using the confidence interval. So you would say, if there is this real risk of rupture, should women try and deliver? But do you have enough evidence to say this rupture is real? So if you find some time, please go and look at this systemic review article. And it had 23 studies with close to 2.5 pregnancies following myomectomy. 18,025 of them were deemed viable by virtue of going beyond 24 weeks. So what they noticed was the rupture occurred in about 11 cases amongst people who had laparoscopic myomectomy, 12,084, and open myomectomy, 541. So it sounds like the decision to say, is this risky, is yes. The quantum of risk is just about 1%. But this study is critical in the sense that it had very clear documentation of pregnancy outcomes in the diagram that I'm going to show you. The interesting one is the one by Dubuisson. That's the one that I referred to you earlier on. If you look at pregnancies, let me remove this, sorry. I want to remove the, anyway, I wanted to remove the header. So you have women who have got myomectomy and they included all pregnancies. In this column, they were looking at the number of women who ruptured before they actually went into labor. So there were 5 of them. They give you an incidence of 1.52. And the ones that ruptured in labor were actually 2. And when you look at this, it would suggest that you are more likely to rupture when you're not in labor if you've had a myomectomy, which would be a little strange, but that's a finding that is there that you can't deny. Right? So the rate of rupture was higher before labor than that obtained when people went into labor. you would think that this is an invitation for us to go for trial of labor if people get to term, because there's less risk. We don't know, the jury is still out. And when we need a bigger sample size, you resort to looking at retrospective cohorts and doing some analysis there. One of these was by Campacotti, an Italian, or reviewed data from Italy between 2002 and 2014. So of this review, they found 152 out of the 460 had pregnancies during this period. 96 of these pregnancies had been, of these women had had laparoscopy. And of these, 73% of them, 73 succeeded in a trial of labor after a myomectomy. The remainder had an elective Caesar. The success rate of this trial was actually 90.4%, and there were no cases of ruptured uteruses reported. You would imagine that maybe if there were no ruptures, perhaps the APGAR and things were poor. But in this case, the neonatal admission was just about 14% with no cases of perinatal death. So it would suggest that the risk of rupture is low and the perinatal outcome is good, which is, what you'd wish for ordinarily. So if you're being tempted, you say, why don't we really go ahead and say people who've had myomectomies should really be aiming for vaginal deliveries? And one of these assessments was done by Village et al. And the idea, I like this idea. The authors wanted to find out if the risk, and you are trying to compare apples with apples now to say the risk of vaginal delivery following myomectomy and compare it to what we all know, vaginal delivery after a C-section. So here it turns out, this was a small sample size, but it turns out that those who were trying delivery after a myomectomy had a higher success rate compared to those who were trying a VBAC. But this was not clinically significant. The important thing was there was no rupture in the trial of labor after a myomectomy compared to 3 subperitoneal ruptures following a C-section. The rates of postpartum hemorrhages were the same. When you find this kind of evidence, you'd say, maybe, hang on, let me look for a bigger sample size, and you go to our systemic reviews. And Clay is one of the biggest review that was done up to 2014. I don't think there's another one after this. They looked at 56 articles. They didn't choose which kind of delivery it was, so they were case series, as long as the outcome for the pregnancy was clearly documented. So there were about 2,000 women who had laparoscopic myomectomy and 705 who had abdominal open myomectomy. So the likelihood of elective Caesar was significantly increased in the laparoscopic group. You may recall that historically we've always been told if you open the endometrial cavity or if the cut is deeper than 50% in the upper segment, you should go for an elective Caesar. So this is probably what was playing around the people's minds around this time. It also could be a reflection of this study looked at a span of over 4 decades. So the first 2 decades may have been an era where it was acceptable for people to go and labor. And then subsequent 6 decades where laparoscopy was coming into force, there was a tendency for higher likelihood of C-section. So it's not clear from the review, and you never get an answer from that kind of review anyway, but it is what it is. So when you look at the scenarios that I have described, it sounds like most women are experiencing ruptures in pregnancy before labor for a variety of reasons. It also sounds like if you labor, you're more likely to succeed. So I just put here some consideration to say, if I told you that this was a 4-centimeter fibroid and another one posteriorly, and this is the end result after excising, this is one of the patients that we did in 2018, would you consider this woman to undergo vaginal delivery? I wish we're in an open meeting and discuss the merits and demerits of whichever decision you choose. I'll give you another one. This is again in 2018. You see this huge pedunculated subserosal fibroid that is, infiltrating a bit into the myometrium, and then you do a myomectomy. This particular patient was complaining of pain. Would this patient be a candidate for a trial of labor? Or would she go for an elective Caesar, assuming she has no obstetric indications for cesarean section? So these are the thought processes that I want us to have and maybe discuss if we've got time. I will go into our experience in this country from doing myomectomies. I'm sorry, this thing is moving on its own. So from September, we've done about 48 laparoscopic myomectomies whose age ranges between 28 and 39 years. I have not been able to follow up on all of them, but I can tell you that from what I have for those who are coming back to the clinic, 17 of them got pregnant. Of those, 3 are currently ongoing. The other 14 have delivered, and they were all term babies, good APGAR scores, but 2 of them had repeat pregnancy, because this is almost a span of 7-8 years. They had repeat pregnancies, and 2 of them had an earlier miscarriage at some stage. So it sounds like people do get to term up to a point where we give them an elective C-section. The time to pregnancy ranged from 6 weeks to 21 months. I want you to notice this. 6 weeks is really early. We operated on this lady in July, and in September, she came to say she was pregnant, despite the counseling that you need to wait for the, recommended 12 weeks. But it's good to notice that patients sometimes don't follow your advice. The 10 that the nulliparous, the ones who had 1 fibroid, 20%, the diameter was huge. That was the reason for the C-section. There were 2 who had 8-centimeter fibroids, 2 who had 10, and the other ones were slightly smaller. Of note is in this cohort, only 2 delivered vaginally, which is about 14.2%. And I'll go through the 2 cases that delivered vaginally, just to get a sense of what. So this lady first saw me in 2014 of February. She's a 28-year-old para 1 at that time. And she had delivered a 3.1 kg baby, but had then come with a secondary subfertility for 2 years. So when we saw her, she had a fibroid that was just anterior and 3 centimeters, not too big, but had another one, which was subserosal. So the reason why we then ended up with myomectomy was we're trying to assess a tubal patency. And at the same time, we decided to do a myomectomy. So about 10 months later, she fell pregnant. And when you're discussing this, I was a bit hesitant to do a vaginal delivery, but she just showed up in advanced labor. I think she really wanted a vaginal delivery, but we never had a back and forth to agree on this. The second case was a 29-year-old para 1 who had delivered a daughter, and she consulted for abnormal uterine bleeding, which had been ongoing for a year, and secondary subfertility of about 3 years. So she had a scan consistent with the 3-centimeter intramural fibroid, which had calcifications. We did the laparoscopy again in the context of, she had secondary subfertility at 29 over about 3 years, and we needed to evaluate a tubal patency. So with this one, the agreement was I have delivered before and I want to try vaginal delivery and it's on me. So we ended up doing a vacuum delivery because she got exhausted in labor, but she succeeded. The rest were elective C-sections, and I can tell you this is what I'm comfortable with. So when I conclude, I hope I have convinced you, and this I'm quoting from one of the summarized meta-analysis. The real problem emerging from the literature in the management of myomas or prior myomectomy with respect to obstetric care is not only how to counsel the patients, because remember, there was one that I couldn't agree with, but also how to counsel gynecologists like myself to stop imposing your fears on patients. But the reason why it's like that is because there's conflicting results from many studies based, so that in the end, we have to individually use our own experience. I think that going forward, it is suitable to collect in the form of a meta-analysis all the data that we have so far, and then plan to carry out randomized control trials so that we can draw more robust conclusions. At this point, I would like to thank you for listening, and I'm happy to take comments on this short presentation. Thank you.
Thank you very much, Dr. Mhlanga, for that interesting presentation. Today we've had several new terms thrown at us, from TOLAM versus TOLAC, to the core technique and Vatiers and Okabayashi and Latsko. So a very interesting day we are having. If we have any questions, please go ahead and unmute your mic or pose questions within the chat. Okay, perhaps people are holding. Okay, Dr. Nyakura, you can go ahead.
Okay.
Thank you, Madam Chair. Thank you, Dr. Mhlanga, for a nice presentation. I think the hesitancy towards the vaginal delivery after myomectomy comes from the complications associated with the fibroids themselves. Initially, this is a woman who has really struggled to conceive. Probably they're in their advanced age, maternal age, and then they probably had to go through a lot to be able to get pregnant. Then you then ask them to deliver vaginal. I think that would be quite taxing in terms of the risk, because NVD is not really predictable, especially when we don't have a adequate monitoring for their labors. So there is a risk of bad outcomes to the baby, in addition to the risk of rupture in these women. Thank you.
Yes, thank you for the comment, Dr. Nyakura. The reason why I'm bringing this up is I hope that you are seeing from the studies that I quoted, and there are many more, that risk, it is real to probably 1, at the most 3% of the populace. So that's why I bring this up for discussion, to say if you are going evidence-based, of course, we're not using the best data set, but that's what I want us to think about. If we get more robust data, then we'll be able to answer that questions correctly. But yes, I share with you, if I see someone who's been struggling to have a baby for this long, I am unlikely to accept taking chances. Thanks.
All right, thank you.
Dr. Buna, I see you have unmuted.
Yes, wonderful. Thank you, Dr. Mhlanga, for the wonderful presentation and thought-provoking issues. Now, the question that I'm also, I don't think we'll ever get an answer from studies, because as you say, they will tend to be retrospective. I don't know whether we'll be able to get a randomized control study and whether that will be ethical. Now, the question about uterine rupture, I'm not sure what really is the issue. Is this the suturing? Or like in your case where the patient were, obviously they don't listen, that in 6 weeks she was back, she was pregnant. So does intracorporeal suturing, because I saw you did intracorporeal, does that make any difference? Is extracorporeal better? Now, obviously in terms of wound healing, how can one predict that there's adequate wound healing? So the question that the wound, for example, the placentation, for example, in a patient who had a myomectomy, if, for example, the placentation is on the other case you showed us on the right, there's going to be, obviously, placental bed is on that side. So those things are things that are out of our control. So will that predispose that patient to a higher chance of rupture because the placentation is on the right compared to if it was on the left? I'll listen to what.
Thanks, Eton. I actually don't have very straight answers to that. The one that is clear from inference is if you look at centers that started doing laparoscopy myomectomy in the, say, 70s, going into 80s, it was started in 79, right? So let's say in the 80s, over time, the same centers are now saying there is no difference in the tensile strength of suturing based on the experience of the surgeon. And I think there is cohort data that is starting to go in that direction. In terms of the learning curve, yes, the learning curve may actually affect the tensile strength of the suturing. But again, you will not get answers from things that are pulled together. Because remember, it's the same discussion with, does double layer suturing of the incision at C-section matter? Some people would say yes, some would say no, some would say yes only if you lock. And you don't, and unfortunately, like you said, you can't randomize people. But you can get large cohorts that are well controlled that might give a bit more detail and are granular. So we will need in the protocols that I am soliciting people to join to say, let's clearly describe in site, number, and everything that goes with the surgery. Because right now, when you read papers, you just read myomectomy was done, but sometimes you'll be lucky if the protocol is described in there. So when we go forward, we now need to describe our protocol, say exactly what we did, which sutures we used, which energy sources we did, how many fibroids did we remove through how many incisions. When you build up that big cohort, it's not possible to randomize people into, it may be if they are willing to, but you may find people who change their minds into you have a fibroid, you had a myomectomy. So do you want to either do a trial of labor or go for an elective season? It will be a very difficult thing to accrue participants, but there are examples of these kind of things that were done. So it's a possibility. Thank you.
Thank you, Dr. Mhlanga. There is also a comment raised by Grant within the chat. Vaginal delivery after myomectomy would be great if the woman is racing after time. That's why I guess we need really great answers. Do you have a response to that? And Dr. Michael still has his hand up.
I don't, maybe I might be misunderstanding Grant's. Is it a comment or a question? I thought he is implying that if you have vaginal deliveries, perhaps your turnover in terms of how many babies you can have in that window of opportunity is higher. Is that correct, Grant? I may be misreading things.
Yeah, absolutely. That's what I'm saying.
Okay, thank you. So in that case, I agree with you. The other aspect of the discussion that I didn't put is, remember that repeat C-sections in myomectomies are not necessarily the easiest to do. So it's not all easy to do a repeat C-section in someone who had a myomectomy. It might actually be hazardous also. So there are some inferences asking, is this not as dangerous? Would it be better if somebody had a vaginal delivery? So it's answers to these things that we need to find.
My hand is down. Sorry, I'd forgotten to take it down.
That's okay, Dr. Nyakura. Do we have any further questions or comments for Dr. Mhlanga? We do have some time. If not, thank you very much.
Can I just add something that, you know, in like what Dr. Mhlanga was saying about this, when you cancel the patient, and then, you know, obviously you can do so much, but now if the patient is obviously an equal contributor to the decision making, then if they choose to go otherwise, I wonder how it will then be in terms of it comes to litigation in the end. How will it work out? Although you advise against, and as you say, I mean, how do you quantify your fear? You know, because if you look at the literature, the numbers are small, but I think one rupture for an older woman is maybe one too many. Hello.
Sorry, I was trying to unmute myself. I don't know how you would really want things not to go the litigation route, because when I look back, it's difficult to find an instance where that discussion took place. So in the end, it's a real problem. The literature itself is iffy. The discussion that you have with the patient in your own rooms, unless if you are now going to write down some paper somewhere, I don't know how it is like in your litigious South Africa, because it's not something that I had given attention to that deeply. But it is a real problem when somebody would then say, but Dr. Mhlanga didn't tell me that this was dangerous. And because half the time when things want to really go north, you would have a rupture, you would have to do a hysterectomy to preserve a life, and then she wakes up and is not able to have babies anymore. I don't know how you're handling it in South Africa, but it's just food for thought for fellow Zimbabweans.
Yes, I think it's difficult. I mean, like they say, whether you record the discussion, but normally, you know, they say documentation. So most of the time you just discuss. But the question which always comes around is, whose figures are you quoting? Because would you guide them with the literature figures, or would you, like in your 48 cases, you would say, okay, in my hands, this is what happened, and then you cancel them using that information, and then you maybe document it. Maybe I think that's all you can do, because as you say, if they want to sue, they will sue. Nothing will stop them, and also it depends on the insight of the judge, because most of the judges also don't have insight, so it's always a bit of a challenge.
I agree. Thank you. And Madam Chair, I didn't know that I had more than 20 minutes. I could have gone on and on, but thank you.
Apologies, one of our speakers couldn't make it, so yes, we gave you more time. Dr. Ziki, did you have a question? Okay.
Sorry, then Dr. Buma addressed it. Sorry, he then addressed the question I was going to ask, so then I had to put my hand down.
Okay, thank you. Thank you very much, Dr. Mhlanga, for that discussion stimulating presentation. So just a few reminders as Emily and Max start sharing their screens. to be able to have your CME points registered, you need to send in your registration details in the chat to our administrator. There are sponsor presentations that are available in the chat in case you miss them during our lunch break. We wouldn't have been able to have this day if we didn't have sponsors such as Ethicon and DRMS, and we're really grateful to them. You realize that today is an election day. The link has been sent in the chat and group. Please follow instructions and vote before our closing time at 5 p.m. And just a reminder, just like you can't vote if you haven't registered, you can't vote if you haven't paid up your subscriptions. So to be able to exercise your vote, kindly pay up and vote for our incoming leaders. So Emily, can you attempt to share your screen so that I can introduce you?
Okay, thank you, Dr. Kwanzura. I'm just doing so.
Okay, I can see your slides, perfect. And I understand you'll be presenting with Max, yes. Okay, so unfortunately, Dr. Jackson Ndlovu couldn't join us this afternoon, which is why we have a little bit more time for discussion. At the same time, Dr. Guja also couldn't join us, but luckily there are two senior registrars within the department with a special interest in gynecology who are going to take up Dr. Guja's presentation. Dr. Maxwell Chimina is a senior registrar within the department with a special interest in gynaecology. Dr. Koti Emily Mkucha did both her undergrad and postgraduate studies at the University of Zimbabwe. She's a senior registrar attached to the oncology firm with a special interest in gynaecology. They will be attempting to answer the question, is laparoscopy the standard of care in endometrial cancer? Emily and Maxwell, you can take the virtual podium.
Okay. Thank you very much, Dr. Chipo Kwanzura, for that humbling introduction, and it's an honor to be on this platform as always. I'm going to be taking you through the first part of this presentation. So we are going to be talking about addressing the question of, is laparoscopy the standard of care in endometrial cancer? So I'm just going to give you a brief summary of a patient who was managed, who had endometrial cancer and who had surgery done laparoscopically. And then I'll hand over to Dr. Maxwell Chimina, who will continue with the discussion. So we are discussing, So we are discussing the case of Mrs. KB, who is a 64-year-old Caucasian para-4 who came in presenting to the rooms of one of the senior gynecologists with a postmenopausal bleeding. So this postmenopausal bleeding had been there for almost a year, but initially she had been managed for vaginal atrophy, and then in all investigations at that time were unremarkable. Then she presented again within the same year with the complaints where a transvaginal ultrasound scan was done again, and this time it showed endometrial thickening. So this patient was counseled adequately about the ultrasound scan findings, and the plan for an endometrial sampling was made, and the patient was in agreement. However, the eventual management was that the patient went for hysteroscopic endometrial, for hysteroscopic and endometrial biopsy on the same setting. So, at this time, she had, like I mentioned, hysteroscopy, whereby they did endometrial curettings, they did endocervical curettings, and they also carried out a cervical biopsy as the cervix was noted to be a little bit nodular. So from these hysteroscopic samples, the patient fortunately actually had two pathological assessment by two different laboratories. So the first assessment showed from the endometrial curettings, it showed that the patient had adenocarcinoma in situ, and from the cervical keratins, it showed that this patient had an adenocarcinoma from the cervix. And then the second pathological result only showed adenocarcinoma of the endometrium, and both pathologists noted that the biopsy, the cervical biopsy itself, showed no pathology. The patient also went ahead to have radiological investigations done. So she had an MRI done of the pelvis. This MRI showed diffuse, like slightly irregular endometrial thickening within an otherwise normal uterus. There was no evidence of pelvic, paraiotic, or mesenteric lymphadenopathy, and there was also no evidence of ascites. So in view of this, the gynecologist who was attending to the patient had a teleconversation with a pathologist and a gynecologist. So from this multidisciplinary conversation, the agreement was that this patient was a candidate for hysterectomy, and the agreement was also that this patient could actually have a laparoscopic hysterectomy. So eventually the patient had total laparoscopic hysterectomy plus bilateral salpingo-oophorectomy for endometrial adenocarcinoma in situ. So post-operatively, the histology results came out, and these showed that the uterus, there was actually 60% myometrial invasion of the uterus with the tumor, but it did not reach the parametrium or the lower segment. Also, there was focus of endometrial adenocarcinoma in situ, which was seen, but comprising small area of the tumor. There was no evidence of lymphovascular space involvement, and the final pathological stage was endometrial adenocarcinoma, FIGO grade 1, stage 1B. So these results were all discussed with the patient and also with the team of the pathologist, gynecologist, and the gynecologist who was attending to the patient. However, the recommendation was that this patient was to be reviewed, but the patient wanted to go ahead with the option of adjuvant treatment. So she eventually had adjuvant treatment in South Africa, where she had adjuvant radiotherapy. Over to you, Dr. Chimina. Max, so you can go ahead and share your screen. Okay, thank you.
Okay, thank you, Emily. Can you see my screen?
Yes, I can see your screen, Max, so please go ahead.
Okay, thank you, Dr. Gwanzura, for the kind introduction. So I'm going to try to answer the question, is laparoscopy the standard of care in the management of patients with early stage endometrial cancer? That's just a brief overview. Endometrial cancer is common, especially in the Caucasian population. That is where it's kind of one of the leading female gynecological cancers. And the good thing is it usually presents early in terms of the way the women present, because of the way it presents, especially with abnormal uterine bleeding. So women tend to present early. And most of the time, about 75% of the affected women will present with early stage endometrial cancer. And suffice to say that the commonest histological variant will be the endometrioid type. And so the standard of care, or rather the management over the years, surgery has been the cornerstone of management, and it encompasses a hysterectomy, bilateral salpingo-oophorectomy. However, this management has evolved over the years. In the past, the women would receive some form of pre or post-operative radiotherapy in combination with the simple hysterectomy. But as the years have evolved, and with better understanding of the relationship of the uterine vector and the risks of nodal disease and recurrences, selective use of surgical staging has been this was followed now by surgical surgery, pelvic and para-aortic modalities in terms of treatment. And so laparoscopic management was introduced early, I think in the era of the 1990s. That is when laparoscopic surgery was introduced in the management of gynecological oncology. And initially it was laparoscopic assisted vaginal hysterectomy to involve total laparoscopic hysterectomy and robotic hysterectomy. So as you all know, the first laparoscopic hysterectomy was done sometime in 1989. I think that was by Charlie and others. And then because of the better optics, better understanding of laparoscopic and evolution of laparoscopic equipment, Kwelu and his team, they managed in 1991 to do the first case of pelvic lymphadenectomy, but this was for cervical cancer. And then a year later, Neshet and team, they also managed to do laparoscopic pelvic and para-aortic lymphadenectomy for cervical cancer. But during these early years, they could only manage to do one side of para-aortic lymph node, that is the right side. And then later on, as I've already said, the first case of laparoscopic assisted vaginal hysterectomy for endometrial cancer now was done in 1994. This was done by Childers and team. So they managed to collect data so as to build up evidence that laparoscopy was kind of comparable to open surgery. So they managed to, they did what was assisted surgical staging of endometrial cancer. So they collected that data, prospective data of 15 patients with clinically stage 1 endometrial cancer, and then did laparoscopic assisted vaginal hysterectomy. What they noted in this study was that there was shorter hospital stay for their patients, and the blood loss was minimum compared to the open surgery. And they were looking at a cohort of patients ranging from 40 to 85 years, the mean around 69 years. So with this developing evidence, other prospective trials were done, and Malu and his team, they also did the laparoscopic assisted vaginal hysterectomy, now compared with total abdominal hysterectomy in patients with endometrial cancer. This was a prospective study. It was conducted between 1995 to 1999, and they were looking at women with figures stage 1 to 3. And so the hysterectomy for the laparoscopic assisted vaginal hysterectomy, it was either a simple or a radical. And then even for the total abdominal hysterectomy, it was a radical or a simple. So they enrolled the patients, and 37 of these women, the 33 had total abdominal hysterectomy. What they noted in this study was that the blood loss and need for transfusion was far way less in those who were offered laparoscopic assisted vaginal hysterectomy. The lymph node yield, the duration of surgery, the post-operative complications were similar in these two groups of patients, and the overall and recurrence-free survival did not differ after following these women. Unfortunately, this study, as you can see, the sample size there, it was kind of a few patients, so more robust data needed to be accrued for minimally invasive surgery to be kind of incorporated as standard of care. So then Maori and they did the laparoscopic hysterectomy comparing lymphadenectomy for a trial. The sample size was a bit 59 patients. And they wanted to compare the feasibility, the safety, of total laparoscopic hysterectomy versus open surgery with or without vaginectomy, depending on the pre-existing tumor, disease-free survival, and recurrence. Highlighted that the mean blood loss, the hospital stay was better with laparoscopy, although there was longer operating time and there was no difference in the disease-free survival or overall survival between the two groups that has been operated. So laparoscopy, they noted it was suitable procedure for the treatment of endometrial cancer and actually could offer better benefits of reduced discomfort, with reduced hospital stays without compromising the degree of oncological radicality. However, with this information, they wanted a multi-center study, randomized multi-center study, to kind of validate this evidence that was being accrued. So then we come to the last trial. I think most people are familiar with this trial. So in the last trial, it's laparoscopic approach to cancer of the endometrium. So it ran over a period of 5 years, from 2005 to 2010, and it was done in a two-stage approach. It was a multinational, I mean, it included countries, I think New Zealand, Australia, and Hong Kong, and 27 these tertiary gynecological centers participated in this study, and they were dealing with stage 1 endometrial 2016, that is about 5 years. The quality of life endpoint is 6 months after surgery, that is from 2005 to 2008, and 332 patients were recruited. Of these patients, total laparoscopy was offered in 190 patients, and open surgery was done in 142 patients. The conversion rate was a bit low, but due to bleeding, poor visibility because of the laparoscopy, or advanced disease were there during the laparoscopy. So operative 30 minutes longer in the total laparoscopic events were more common with the open surgery, and quality of life assessments favored a total laparoscopic hysterectomy versus open surgery. So this was the first stage of the last trial. Then they now wanted to look at the disease-free survival and overall survival. So as I said, the study started initially in 2005 up to 2010. And now the cohort of patients, that is 752, a total of treatment, and we followed up to 4.5 years follow-up, and they now look at the disease-free survival, that is the period from surgery until recurrence or development of new cancer or death of the patient within the 4.5 years. So the disease-free survival was 81.3%, in the total laparoscopic hysterectomy. This was comparable, and there was no difference in the overall survival of the patient. And then the later study that came was the LAP2 trial. I think most people are aware of the LAP2 trial. It was the largest and comprehensive, it gave the largest and comprehensive data set in terms of the management of patients with endometrial cancer, comparing open versus minimally invasive surgery. So a cohort of patients that were recruited in a 2:1 ratio favoring laparoscopy. It was done by the GOG group, and they were offering total abdominal hysterectomy, bilateral swapping of rectomy, so cytology, plus or minus pelvic and parabiotic lymphadenectomy. So what they noted was that yes, there were longer operating times with laparoscopy, but there were few post-operative complications. The duration of hospital stay was far less with laparoscopy, and there was no difference in terms of detection of advanced disease. There was similar lymph node between the two groups, and in terms of conversion to open, the conversion to open, the rate was about 26%, meaning 74% of the patients who initially had started laparoscopy completed their laparoscopy. So the conclusion was that laparoscopic surgical staging for uterine cancer is feasible and safe in terms of short-term and long-term, short-term outcomes and result in fewer complications and hospital stay without any difference in terms of recurrence and disease-free survival. So armed with this information from these studies that has evolved over the years, minimally invasive surgery is part of standard of care in the management of endometrial cancer because it is comparable endpoints, that is similar number of nodes are removed, the recurrence and disease-free survival are the same, and it has actually more benefits in terms of shorter hospital stays, recovery, and better quality of life indicators. However, the challenge remains on how to increase minimally invasive surgery training. Thank you.
Thank you, Max and Emily, for the presentation. So basically, you have answered yes to the question of whether laparoscopy should be the standard of care for endometrial cancer, if I got your presentation right.
Yes,
thank you. Do we have any questions from the floor? I don't see any raised hands.
Yes, I've got just one. Can I go ahead?
Yes, you can go ahead.
Yes, I just wanted to find out in this patient, lymph node assessment, sentinel lymph node assessment, was it done or was it not considered, or was it not applicable? I suppose maybe I'm not talking to the wrong people, maybe.
Lymph node assessment was not done in this patient. Unfortunately, in Zimbabwe, we cannot do sentinel lymph node dissection due to the lack of nuclear medicine in department. But however, in this patient, it was not done. And it was one of the pointers that was put up for post-surgery, discussing about management post-operatively, as it was considered that since it was not done, she was a candidate who could have also needed adjuvant treatment.
Thank you. Dr. Smango, do you want to make a comment? I see you are unmuted. Okay, so thank you to our speakers, Dr. Chimina and Dr. Mkucha, as well as Dr. Mhlanga, for this very short but exciting session that we've had. Today it's been difficult to actually leave the meeting. At some point I wanted to do errands, but then the program was just too exciting to leave. So at this point, I would like to hand over to Prof. Srandasara, who is current president of the ZSGE and our mentor, to give us the closing remarks.
Thank you very much, Chipo. I don't know if everybody is hearing me.
We can hear you very well, Prof.
Okay, thank you very much, everybody who has participated in this in today's meeting. can I just ask one small request? Wherever you are, can we all clap our hands for these wonderful people who gave us the discussions and the presentation? Please, if you can. Thank you. The presentations were of the highest standard. What I see from this presentation is that the future of ZSGE and also of endoscopy surgery is in very good hands indeed. We have got the mentees who are very enthusiastic. We also get, we have our mentors who are very enthusiastic, ready to give their time to assist the development of all these young people who are taking up endoscopy surgery. One theme which has come up from today is that anatomy is very important. And I hope every one of us will go back perhaps and look at anatomy in a different way from what we were doing. And as a society, we hope that there will be more cadaver dissection, there will be more anatomy demonstrations in the anatomy department in the near future. We have also learned that cervical cerclage or transabdominal cerclage is possible. We haven't tried it here in Zim, but we are hoping that with the experience Eton has, maybe one day we'll call him with a few of the patients who require that operation, and then he can demonstrate to us in person. And then from down under, from New Zealand, there were excellent presentation on VNOT, on endoscopic surgery. And again, we would want to thank them for the insight into the future of endoscopy. And then maybe finally on this, we need future leaders. Obviously, we need future leaders. And endoscopy should remain a practical subject. And we would want to continue helping each other. My own advice would be perhaps those who are doing endoscopy, at the beginning, try and do it together, 2 people or even 3. I know Dr. Nemachena is very happy to assist anyone who would want to do endoscopic surgery. Please utilize him. So those are my closing remarks. I would want to move on then to the, if I can take the chair, to the general meeting for 2021. My presentation will not be very long. We had a very long and long day, so we would want to reduce the time we continue spending here. The first item on the agenda, obviously, is the procedural matters. If there are any apologies, from what I observe, we have more than 60 members who are paid up. So on the platform, the last time I checked, we were more than 30. So in my view, then we constitute a quorum, and whatever decisions we make will be valid at law. But if there's anyone who has got a different view, please let me know. Then the next item on the agenda is minutes of the last meeting. We had a meeting in December 2020, annual general meeting, and the minutes are available. I don't know if there's anybody else who has looked at the minutes of that meeting. The matters arising from that meeting is probably one, just to highlight that we were still working out how we could purchase the endoscopy equipment. We had Dr. Solanki, we had offered to purchase one of the items, and that offer still remains. So once we can get the quotations which are so required, then we can purchase the equipment. We also had a donation from Dr. Kundojgiwa, and is still to ship it to us here at home. From that introduction, I would want to remind you of our constitution. Our constitution was designed in 2018. It was designed in 2018, and it requires leadership. And that's what we are going to choose today, to choose leadership. And I just want to emphasize that the leaders who are chosen can serve only 2 terms, not more than 2 terms. After this, the next item is that I would want to move on to declare that the following ZSGE posts are now vacant: the president, the vice president, the secretary general, the treasurer, and the committee members. This then opens up the nominations and the elections. And with this, I would want to hand over to Dr. Nyakanda so that he can conduct the elections. After the elections, if we still have time, then whoever the nominee or whoever the leaders are chosen, we can then tell them maybe in some detail what we have been doing, and then they can decide whether they want to continue with that or not, or whether they want to choose a new path. Thank you very much. I hand over to the chairperson. Dr. Nyakanda, if you are available, I've handed over to you.
Good afternoon, Prof. Let me just phone him. I think he's not on the platform right now. Hello, Prof.
Yes.
So currently his phone is unreachable. He's not yet picked up his phone. I don't know if it's possible for perhaps to continue and then he will continue trying to get a hold of him. Then he'll join.
Okay, that's all right. The next item on the agenda is reports. The report is from Felix, if he has got anything to report on the fundraising committee activity. Then Dragana, if she has got anything to report on external relations and some of the fundraising activities she has done. And then Tarisai to report on some of the proposed ZSG activities for 2022. And where possible, if we can get reports from our representatives from South Africa, United Kingdom, and New Zealand, Eton and Joseph, if they've got something to report.